Welcome to the Deep Dive, the show where we slice through the complexity of a topic, distill the absolute essence, and give you a shortcut to truly mastering information, even really at an elite professional level. Today, we're not just scratching the surface, we're taking an exhaustive, deep plunge into the incredibly intricate yet profoundly vital world of the spinal cord.
It's a fascinating and absolutely critical structure.
It really is. Imagine this scenario. It's a real-world case that underscores just how vulnerable this central nervous system conduit truly is. Picture a 35-year-old man, picture of health, enjoying a horseback ride.
Okay.
He attempts to clear a farm gate, but the horse refuses, violently throwing him to the ground. His head strikes a log, forcing an excessive, really brutal flexion of his head and neck.
Oof. That sounds severe.
Yeah. In the emergency department, after regaining consciousness, the devastation is immediately apparent. Severe neurological deficits in both his upper and lower extremities.
Both arms and legs affect.
Exactly. A lateral radiograph of his cervical spine confirms the horror fragmentation of his fourth cervical vertebra, C4, with a bony fragment driven backward, directly impinging on that precious cord.
Right. And that impingement is key. It's a truly stark, almost immediate reminder of just how critical the spinal cord is. Spinal cord injuries, as this case tragically illustrates, are not only common but, well, profoundly catastrophic.
They really are.
They can stem from a wide array of incidents. Devastating motor vehicle and motorcycle accidents, simple falls, high-impact sports injuries, gunshot wounds, other types of vertebral fractures, infections, tumors, or even something like a herniated intervertebral disc.
A long list.
It is. And the profound life-altering disability that so often results from these injuries underscores an undeniable truth. Understanding this vital part of our central nervous system isn't just academic, it's absolutely paramount.
Absolutely. So, for you today on the Deep Dive, our mission is to achieve a deep mastery of the spinal cord. We'll meticulously explore its intricate structure, delve into the precise positions and functions of its ascending, descending, and intersegmental tracts.
The highways, essentially.
Exactly, the information highways. And then crucially unpack how various injuries manifest. We're going to pay particular attention to whether a specific tract crosses the midline, and if so, exactly where that crossover occurs.
That crossing point, the decussation, is so important for localization.
It is. This level of detail is key for anyone aspiring to truly understand neurological function. So prepare for some genuine aha moments, because we're going to take even the densest, most complex neuroanatomical topics and make them not just digestible, but deeply relevant and understandable, right down to the professional level. Let's begin. IS. The spinal cord's bony sanctuary. A look at the vertebral column. Okay, let's unpack this foundational element. Before we even journey into the delicate spinal cord itself, we must thoroughly understand its primary bodyguard, its central fortress, the vertebral column. Think of it as the body's central bony pillar, an engineering marvel that supports the weight of our skull, anchors the pectoral girdle and upper limbs, cradles the thoracic cage, and perhaps most profoundly, transmits our entire body weight down through the pelvic girdle to our lower limbs.
Yeah, and what's truly remarkable here is its ingenious dual role, really a masterclass in biomechanics. While it serves as this robust central pillar of support, its foremost and most critical function is the supreme protection it offers to the exquisitely delicate spinal cord.
Right.
Its vital nerve roots and the covering meninges that lie within its specially adapted cavity. It's a complex, living structure, showcasing both incredible strength and remarkable flexibility.
And that very flexibility is not just an incidental feature. It's absolutely fundamental to our everyday movement. So let's dissect its anatomy. The vertebral column is composed of 33 individual bones called vertebrae.
Right, 33.
We have 7 cervical vertebrae in the neck, 12 thoracic in the chest, 5 lumbar in the lower back, 5 sacral, which are fused together to form the sacrum, and then 4 coccygeal, with the lower 3 of those typically fused. This segmented design, achieved through the individual vertebrae, the sophisticated joints between them, and those incredible pads of fiber cartilage we call infravertebral discs, makes it a highly flexible and adaptable structure.
Yeah, and those discs are critical.
In fact, these discs alone contribute significantly, making up about a quarter of the column's entire length.
A quarter. That's substantial, indeed. While each region has its unique characteristics, a typical vertebra, at its core, shares a common architectural pattern. Anteriorly, you find a stout, rounded body, the main weight-bearing component.
Okay.
Posteriorly, there's the vertebral arch. These two components, the body and the arch, together encircle and define a crucial space, the vertebral foramen.
Right, the hole in the middle.
Exactly. This foramen, when stacked up with those above and below it, forms the continuous vertebral canal, the direct and highly protected pathway for the spinal cord and its coverings.
Got it.
Delving deeper into the vertebral arch itself, it's formed by a pair of cylindrical projections called pedicles on its sides, extending posteriorly from the body,
Pedicles, okay.
and a pair of flattened, plate-like structures called laminae that complete the arch posteriorly, forming its roof.
And then, projecting from this arch, you find 7 distinct processes, each acting essentially as a sophisticated lever for the attachment of our muscles and ligaments, allowing for precise movement and stability.
Right, levers for movement.
There's one spinous process, projecting directly backward from the point where the 2 laminae join. That's the bony ridge you can feel along your back.
The bumps.
2 transverse processes extend laterally from the junction of the laminae and pedicles. And then vitally, there are 4 articular processes arranged vertically, 2 superior and 2 inferior. These articulate with the vertebrae immediately above and below, forming highly specialized synovial joints that permit controlled movement.
It's also imperative to grasp how these individual vertebrae interact to create functional openings. The pedicles, those cylindrical projections, possess distinct superior and inferior notches on their borders.
Notches, right.
When one vertebra articulates precisely with another, these notches align perfectly, forming what are known as the intervertebral foramina.
Ah, the holes in the sides.
Exactly. These foramina are anatomically critical because they serve as the conduits for the transmission of the spinal nerves and their accompanying blood vessels. It's within these very foramina, enclosed by their dural coverings, that the anterior or motor nerve roots,
Carrying commands out.
precisely, and the posterior or sensory nerve roots carrying information in, unite to form the segmental spinal nerves, the very nerves that extend out to innervate our body.
Now let's focus on the remarkable connections between these bones. The primary joints between the vertebral bodies are classified as cartilaginous joints, specifically formed by those robust intervertebral discs we mentioned.
Yes, the discs again.
These discs are not uniformly thick. Their thickness varies considerably, being greatest in the cervical and lumbar regions. Why there?
Well, it makes sense, precisely because these are the areas of the vertebral column where the most extensive and complex movements occur. It's a direct correlation between structure and function.
Right. More movement, thicker discs.
Exactly. And their vital, almost miraculous role as shock absorbers cannot be overstated. They're indispensable for cushioning the vertebral column, particularly against sudden, significant increases in load, like an impact or a jump.
Okay.
This extraordinary resilience, however, does undergo changes with age. Each intervertebral disc is structurally composed of 2 distinct parts. Peripherally, there's the annulus fibrosus.
Annulus fibrosus.
This is a tough, concentric ring of fibrocartilage, incredibly strong, and firmly attached to the vertebral bodies above and below, as well as to the anterior and posterior longitudinal ligaments.
Got it. The outer ring.
Right. Centrally, encased within this ring, lies the nucleus pulposus. In a young, healthy individual, this is an ovoid, semi-fluid, gelatinous mass, normally held under considerable internal pressure. It's typically situated slightly more posteriorly within the disc.
The jelly center. Okay, here's where it gets really clinically interesting and where we directly connect back to our patient's devastating injury. The semi-fluid, almost gel-like nature of that nucleus pulposus is what allows the adjacent vertebrae to subtly rock forward or backward, enabling the smooth, flexible movements of our spine.
Right, it facilitates movement.
But imagine a sudden, immense compression load, like our horse rider hitting that log. This forces the nucleus pulposus to flatten. If that outward thrust, that internal pressure, becomes too great for the surrounding annulus fibrosus to contain, the annulus can rupture.
Ah, the herniation.
Exactly. This catastrophic event allows the nucleus pulposus to herniate, to protrude directly into the vertebral canal. This herniation can then directly press on and irritate the delicate spinal nerve roots, the spinal nerve itself, or in severe cases, even the spinal cord itself, causing profound neurological deficits.
And this risk increases with age, right?
Yes, this phenomenon becomes increasingly likely with advancing age as the nucleus pulposus naturally becomes smaller, losing some of its fluid content and being gradually replaced by fibrocartilage.
It gets drier, less jelly-like.
Precisely. Concurrently, the robust collagen fibers of the annulus fibrosus undergo degenerative changes, rendering it less capable of containing the nucleus under the immense mechanical stresses of daily life, or as in our patient's case, a sudden traumatic impact.
So the container weakens too. To maintain the overall stability of this marvelously flexible column, the vertebral column relies on a sophisticated series of incredibly strong ligaments. Foremost among these are the continuous anterior and posterior longitudinal ligaments.
Okay, two main ones.
The anterior ligament is broad and exceptionally strong, running like a band from the base of the skull all the way down to the sacrum, firmly attached to the anterior and lateral surfaces of the vertebral bodies and intervertebral discs. Strong one in front. In distinct contrast, the posterior longitudinal ligament is much weaker and narrower, coursing along the posterior borders of the vertebral bodies, within the vertebral canal itself, and mainly attached to the intervertebral discs.
Weaker one behind, inside the canal. Got it. Beyond these major longitudinal stabilizers, we also have several other crucial ligaments. There's the supraspinous ligament, connecting the very tips of adjacent spinous processes.
Tip to tip.
The interspinous ligament, connecting adjacent spinous processes, and the intertransverse ligaments, which run between adjacent transverse processes.
Lots of connections.
Indeed. The ligamentum flavum, meaning yellow ligament, is particularly vital. It connects the laminae of adjacent vertebrae, and its unique elastic composition allows for flexibility while providing strong support.
Yellow ligament, elastic. Okay.
Notably, in the cervical region, both the supraspinous and interspinous ligaments become greatly thickened and specialized, forming the exceptionally strong ligamentum nuchae, which you can easily feel at the back of your neck.
Ah, the nuchal ligament.
Right.
For a comprehensive understanding, it's also essential to appreciate the intricate nerve supply to these vertebral joints. The cartilaginous joints located between the vertebral bodies involving the intervertebral discs are innervated by small meningeal branches that arise from each spinal nerve.
Okay, simple enough for the discs.
However, the synovial joints, those between the articular processes, receive a more complex innervation pattern. Branches from the posterior rami of the spinal nerves, with any particular level receiving nerve fibers from two adjacent spinal nerves.
Two nerves for each joint.
Yes, providing a degree of redundancy and intricate sensory feedback.
So when we directly connect this back to our initial patient, his cervical C4 fracture with that dramatic backward displacement of a bony fragment vividly illustrates the fundamental principle of protection offered by the vertebral column. In his specific case, that protective integrity was catastrophically compromised. The very structure exquisitely designed to shield his spinal cord failed under immense force, directly leading to the devastating neurological deficits he experienced.
It's a perfect, albeit tragic example of how the structural and functional integrity of this bony sanctuary is not just important, but absolutely paramount for neurological well-being. 2. Unpacking the central conduit, the spinal cord itself.
Moving inward, past the protective bony fortress, let's turn our attention to the spinal cord itself, the central conduit, the superhighway of our nervous system.
The main cable.
Exactly. This remarkable structure, roughly cylindrical in shape, begins superiorly at the foramen magnum, a large opening at the base of the skull, where it seamlessly becomes continuous with the medulla oblongata, the lowest part of our brainstem.
Right, connects directly to the brainstem.
Inferiorly, in adults, the spinal cord typically tapers to a point, terminating at the lower border of the first lumbar vertebra, or L1.
L1 in adults.
In young children, it's relatively longer, ending slightly lower, at the upper border of the third lumbar vertebra, L3. This difference is a critical clinical detail, as we'll soon see.
Yeah, that L1 versus L3 difference is crucial for things like spinal taps. What's fascinating and incredibly clinically relevant about its position is that the spinal cord only occupies the upper 2/3 of the vertebral canal in adults.
Only 2/3, so there's empty space below.
Exactly. This leaves a significant space inferiorly, a crucial anatomical consideration for various medical procedures. Providing further multi-layered protection are 3 robust fibrous membranes, collectively known as the meninges.
The meninges.
From outermost to innermost, these are the dura mater, a thick, tough outer membrane.
Dura, tough mother.
The arachnoid mater, a delicate, spiderweb-like middle layer.
Arachnoid like a spider web.
And the pia mater, a thin, transparent membrane that directly adheres to the surface of the spinal cord, intimately following its contours.
Pia, gentle mother, right on the cord.
Precisely. And, of course, the ever-present cerebrospinal fluid, or CSF, which completely surrounds the spinal cord within the subarachnoid space, the space between the arachnoid and pia mater, offering yet another critical layer of cushioning against mechanical trauma and providing nutritional support.
So bone, then dura, arachnoid, CSF, pia, then the cord itself.
Yeah.
Layers of protection.
Exactly. Multiple layers.
But the spinal cord isn't just a uniform cylindrical cable. It exhibits two distinct fusiform or spindle-shaped enlargements along its length.
Right. It bulges out in places.
There's the cervical enlargement, located in the lower cervical region from about C4 to T1. This swelling is the origin of the brachial plexus, the intricate network of nerves that supplies all the muscles and skin of our upper limbs, from our shoulders to our fingertips.
Brachial plexus for the arms. Makes sense. It needs more circuitry there.
Then there's the lumbar enlargement, found in the lower thoracic and upper lumbar regions from about T11 to L1. This larger swelling gives rise to the lumbosacral plexus, which similarly innervates our lower limbs.
Lumbosacral plexus for the legs. Again, more nerves needed.
These localized swellings are direct functional correlations to the significantly increased number of nerve cells and fibers required to supply the extensive musculature and sensory input of our limbs.
Form follows function. Inferiorly, the spinal cord undergoes a characteristic tapering, forming a cone-shaped end known as the cambius medullaris, typically at the L1 vertebral level in adults.
Cambius medullaris, the cone end.
From the very apex of this cambius, a delicate thread-like prolongation of the pia mater descends, called the filum terminale.
Filum terminale, terminal thread.
Exactly. This specialized filament descends within the lumbar cistern, part of the subarachnoid space below the cord, and ultimately attaches to the posterior surface of the coccygus, effectively anchoring the spinal cord inferiorly within the vertebral canal.
So it anchors the bottom end.
On the surface of the spinal cord itself, you could distinguish a deep longitudinal groove anteriorly, known as the anterior median fissure, and a shallower furrow posteriorly, the posterior median sulcus.
Fissure in front, sulcus in back. Got it. Along its entire length, 31 pairs of spinal nerves emerge, intricately attached to the cord. Each spinal nerve is formed by the union of two distinct components: an anterior or motor root carrying efferent motor signals away from the cord,
Motor goes out the front.
and a posterior or sensory root carrying efferent sensory signals towards the cord.
Sensory comes in the back.
Each root, in turn, is actually composed of a series of smaller filaments called rootlets that extend the entire length of their corresponding spinal segment. Crucially, every posterior nerve root also possesses a prominent swelling called the posterior root ganglion.
Ah, the ganglion. That's important.
Yes, this ganglion is vital because it contains the cell bodies of all the peripheral and central sensory nerve fibers, marking where the sensory journey often truly begins before entering the spinal cord proper.
So the sensory cell bodies live outside the cord in that ganglion. Now let's cut into the spinal cord to reveal its internal architecture. On cross-section, the spinal cord reveals two fundamental components: an inner core of gray matter, which, as we noted earlier, has a distinctive H shape.
The butterfly shape.
Right, or an H surrounded by an outer covering of white matter. This gray matter, which is where neuronal processing largely occurs, is a complex mixture of multipolar nerve cell bodies, an intricate supportive network of neuroglia, and a rich supply of blood vessels.
Gray matter is the processing center.
Exactly. That H-shaped pillar consists of prominent anterior gray columns, or horns, and posterior gray columns, or horns, which are united across the midline by a thin strip called the gray commissure. Right at the center of this gray commissure, you'll find a minute canal, the central canal.
What's really interesting and a key diagnostic detail is that you'll also find a small lateral gray column, or horn, but only specifically in the thoracic and upper lumbar segments of the cord from T1 to L2, L3.
Only in the thoracic and upper lumbar. That suggests a specific function, maybe autonomic.
Precisely. We'll get to that. And here's a fundamental correlation, a true aha moment for understanding spinal cord anatomy and function. The total amount of gray matter at any given level of the spinal cord is directly proportional to the amount of muscle innervated at that specific level, and also the amount of sensory input received.
So more muscle means more gray matter.
Exactly. This is precisely why the gray matter is at its absolute greatest size within those cervical and lumbosacral enlargements we discuss. Those are the levels supplying the extensive and densely innervated musculature and sensory fields of the upper and lower limbs.
Makes perfect sense. Within this H-shaped gray matter, especially within its horns, we find distinct, functionally specialized groups of nerve cells. These are, in essence, the command and control centers for various somatic and autonomic functions.
Okay, the control centers within the gray matter.
In the anterior gray column, we primarily encounter motor nerve cell groups. These include the large, robust alpha efferents, which are multipolar neurons whose axons exit the cord to form the anterior roots and directly innervate our skeletal muscles.
Alpha efferents, the big movers.
Right. These are the main powerful drivers of voluntary movement. Alongside them are smaller, yet equally vital, gamma efferents. These are also multipolar neurons whose axons form anterior roots, but specifically innervate the intrafusal muscle fibers located within neuromuscular spindles.
Intrafusal fibers. Those are inside the muscle spindles.
Yes, playing a sophisticated role in regulating muscle tone and proprioception, kind of like fine-tuning the system.
Okay, alpha for power, gamma for tuning. So to really understand these anterior gray column nerve cells, we can think of them as organized into three functional divisions. First, the medial group, which is present in most, if not all, segments of the spinal cord.
Medial group everywhere.
This group primarily innervates the skeletal muscles of the neck and trunk, including our vital intercostal muscles for breathing and our abdominal musculature. Second, the central group, which is the smallest and found only in a few specific cervical and lumbosacral segments.
Central group, smaller, more specific locations.
This central group houses some incredibly vital nuclei. The phrenic nucleus, C3-C5, which is absolutely critical for breathing because its neurons innervate the diaphragm.
Phrenic C3-4-5 keeps the diaphragm alive.
That's the one. The accessory nucleus, upper 5 to 6 cervical segments, whose neurons contribute to the spinal part of the accessory nerve, innervating the sternocleidomastoid and trapezius muscles.
Accessory for neck and shoulder muscles.
And the lumbosacral nucleus, L2S1, though the precise distribution of its axons isn't fully understood. Finally, there's the lateral group, which is prominently present in the cervical and lumbosacral enlargements, and as its name suggests, it's responsible for innervating the vast skeletal muscles of our limbs.
Lateral group for the limbs. Makes sense, found in the enlargements. Moving to the posterior gray column, we delve into the intricate world of sensory processing centers. One particularly important group is the substantia gelatinosa.
Substantia gelatinosa sounds delicate.
It is. It's located at the very apex, the dorsal tip, of the posterior gray column, and extends throughout the entire length of the spinal cord. Composed largely of Golgi type 2 neurons with short axons, it serves as a primary receiving station for afferent fibers, primarily concerned with pain, temperature, and crude touch information entering from the posterior root.
So first start for pain, temp, and crude touch.
Right. But here's a crucial insight. The substantia gelatinosa doesn't just receive, it also receives significant input from descending fibers originating from higher supraspinal levels of the brain.
Ah, so the brain can talk back to it.
Exactly. This anatomical connection strongly suggests its vital, almost gatekeeping role in pain modulation, allowing the brain to influence how much pain we actually perceive. At these synapses, neurotransmitters like substance P, a slow-releasing peptide with wide diffusion.
Substance P for slow pain.
Not to be involved, yes.
Yeah.
And glutamate, a fast-acting amino acid with more localized effects, are thought to be key players.
Then, situated just anterior to the substantia gelatinosa, you find the nucleus proprius, which extends throughout the entire length of the spinal cord.
Nucleus proprius, the main bulk.
This group constitutes the main substantial bulk of the posterior gray column cells. It primarily receives fibers from the posterior white column fibers, conveying crucial information related to proprioception, our incredibly sophisticated sense of body position and movement, as well as fine touch discrimination, like two-point discrimination and vibratory sense.
So proprioception, vibration, fine touch go here. The body's detailed GPS info.
Exactly. Think of this nucleus as where the body's detailed internal GPS information, critical for fine motor control and spatial awareness, is initially processed.
Continuing our exploration of the posterior gray column, at its base, extending specifically from the C8 spinal segment caudally down to the L3, L4 segments, is the nucleus dorsalis, more commonly known as Clark column.
Clark's column C8 to L34.
This nucleus is characterized by its large nerve cells and is intimately associated with proprioceptive endings, particularly from neuromuscular spindles and tendon organs. It's another pivotal station for transmitting unconscious body awareness.
Unconscious awareness.
Yes, providing a constant real-time feed of proprioceptive information that doesn't reach conscious awareness but is vital for motor control, especially coordinating movement.
Okay, so it feeds the cerebellum, perhaps.
Precisely. And located laterally to the nucleus dorsalis, spanning from T1 to L3, is the visceral afferent nucleus, which, as its name implies, is believed to be the primary recipient of afferent information from our internal organs.
Visceral efferent information from the organs, the gut feelings.
You could say that, yes.
And finally, circling back to those small lateral gray columns, which, remember, are only found in the thoracic and upper lumbar segments, T1 to L2, L3.
Right, the ones we suspected were autonomic.
These house a critically important group of cells, the intermediolateral group. These small, specialized cells are the origin of preganglionic sympathetic fibers.
Sympathetic nervous system starts here.
In essence, this is where the fight-or-flight commands of our autonomic nervous system are initiated within the spinal cord. A similar corresponding group of cells found in the S2, S4 sacral segments gives rise to preganglionic parasympathetic fibers,
Parasympathetic in the sacral region.
which are responsible for our rest and digest responses.
Okay, so lateral horn, autonomic. Sympathetic and thoracolumbar, parasympathetic and sacral. Connecting all these fascinating gray matter components across the midline is the transverse gray commissure, which unites the H-shaped gray matter from side to side. Right in its very center, there's a minute opening, the central canal.
The tiny hole in the middle of the H.
This central canal is continuous superiorly with the central canal of the medulla oblongata in the brainstem, and it eventually opens into the fourth ventricle of the brain. Inferiorly, within the columnus medullaris, it expands slightly into a small fusiform dilatation called the terminal ventricle before finally ending within the filum terminale.
So it connects up to the brain's ventricle system.
Yes, it's filled with cerebrospinal fluid and lined by specialized ependymal cells, effectively providing a continuous, albeit tiny CSF pathway through the center of the cord.
Surrounding this intricate H-shaped gray matter is the white matter, which derives its characteristic white appearance from the high proportion of myelinated nerve fibers it contains, the myelin sheath being a fatty insulation that increases nerve conduction speed.
White matter, myelinated axons, the highways.
For clear anatomical description, this white matter is functionally divided into three major regions, or columns, also known as funiculi: the anterior white column, the lateral white column, and the posterior white column. These divisions are based on their relationship to the emergence or entry points of the nerve roots and the central midline.
Anterior, lateral, posterior columns. These white columns are, quite literally, the grand information highways of the spinal cord. They are primarily composed of tightly packed bundles of myelinated nerve fibers, along with supportive neurolia and a network of blood vessels.
Okay.
The precise arrangement of these nerve fiber tracts, their origins, destinations, and functional roles, has been painstakingly deduced over decades through extensive animal experimentation and meticulous human studies involving the tracing of degenerative nerve fibers resulting from various injuries or diseases.
So a lot of detective work involved.
A huge amount. While specific tracts are indeed concentrated in certain distinct areas, it's important to remember that considerable functional overlap exists. For the purpose of our deep dive, we rigorously classify these numerous spinal tracts into three primary functional divisions. Ascending tracts,
Carrying info up.
descending tracts,
Sharing commands down.
and intersegmental tracts, which facilitate local communication within the spinal cord itself.
Connecting different levels locally? Okay, makes sense. 3, the ascending highways. Bringing sensation to consciousness. So let's now begin our ascent, a fascinating journey up the spinal cord. When sensory nerve fibers, the very first messengers of sensation, enter the spinal cord from the periphery, they are not simply thrown into a jumble.
No, it's highly organized.
Instead, they are immediately sorted and meticulously segregated into specific, highly organized nerve bundles or tracts within the white matter. Some of these fibers are designed for local communication, simply linking different segments of the spinal cord. But a great many others constitute the true ascending highways, carrying vital sensory information all the way from the spinal cord to higher processing centers within the brain itself.
Right up to the cortex, often.
Forging that indispensable connection between our body and our conscious perception.
These ascending tracts conduct two fundamental types of afferent information, some of which ultimately reaches our conscious awareness, while other crucial information operates unconsciously, often for motor control and coordination.
So conscious and unconscious streams.
Exactly. Firstly, we have extraceptive information, which originates from external stimuli acting on the body. Think of the myriad sensations of pain, temperature, and touch that we experience from our skin.
Exteroceptive from outside.
Secondly, and equally vital, is proprioceptive information. This originates from within the body, specifically from highly specialized receptors located in our muscles, tendons, and joints, providing our brain with a continuous, real-time update about our body's precise position and its dynamic movements in space.
Proprioceptive from inside. body position sense.
Hmm.
And this journey of sensory information follows a remarkably consistent and organized anatomical pathway. In its most common form, the pathway that leads to conscious awareness typically involves a three-neuron chain.
The classic three-neuron relay.
The first-order neuron has its cell body situated in the posterior root ganglion of the spinal nerve, meaning it's outside the spinal cord itself.
Okay, cell body in the ganglion.
Its peripheral process extends out to connect with the specific sensory receptor ending in the body. Its central process then enters the spinal cord through the posterior root, where it forms a synapse, a point of communication with the second-order neuron.
The second-order neuron then represents a critical juncture. Its axon arises and embarks on a crucial step. It decussates.
Decussates crosses over.
This means it crosses over to the opposite side of the central nervous system. Once crossed, it ascends to a higher level within the CNS, where it forms another synapse with the third-order neuron.
Okay, second one crosses and ascends.
This third-order neuron is usually strategically located within the thalamus, often referred to as the brain's sensory relay station.
Thalamus, the big relay center.
From the thalamus, this third-order neuron gives rise to a projection fiber that then passes to a specific sensory region of the cerebral cortex, where conscious perception truly takes place.
And finally, to the cortex for awareness.
While this three-neuron chain is the most common and classic arrangement, it's important to note that some afferent pathways may utilize more or fewer neurons. What's particularly fascinating is that many branches of these ascending pathways don't just go directly to the cortex, they also provide significant input into the reticular formation in the brainstem.
The reticular formation, what does that do?
This reticular formation then plays a crucial role in activating the cerebral cortex, helping to maintain our state of wakefulness and general arousal. Kind of like a volume control for consciousness.
Ah, okay. So it keeps us awake and alert.
Exactly. Other branches also send signals directly to motor neurons, participating in the fundamental process of reflex muscular activity.
All right, let's dive into the specifics of these crucial pathways, beginning with the sensations of pain and temperature. The specialized receptors for these sensations, located in our skin and other tissues, are remarkably simple. They are free nerve endings.
Just bare nerve endings.
Pain impulses are then transmitted to the spinal cord via two distinct types of nerve fibers, each responsible for a different quality of pain. First, there are the fast-conducting A-type fibers.
Of delta for fast pain.
These are relatively thick and myelinated, allowing them to carry initial, sharp, acute, or pricking pain at impressive velocities, ranging between 6 and 30 meters per second. This is the immediate, localized pain you feel.
Fast, sharp, localized. Like a pinprick.
Then we have the slow-conducting C-type fibers. These are thinner and unmyelinated, transmitting that more prolonged burning, aching, or throbbing pain at much slower velocities, between 0.5 and 2.0 meters per second.
C fibers for slow, aching, burning pain. Much slower.
Sensations of heat and cold also utilize both A and C fibers depending on their intensity.
The journey of these pain and temperature sensations from the periphery to consciousness is intricately choreographed. The first-order axons, originating from their cell bodies in the posterior root ganglion, enter the spinal cord and proceed to the very tip of the posterior gray column.
Okay, into the posterior horn tip.
Here, they undergo a crucial branching. They divide into ascending and descending branches. These branches then travel for one or two spinal segments within a specialized bundle known as the posterolateral tract of Lissauer.
Lissauer's tract running up and down a bit first.
Right. Ultimately, these first-order fibers terminate by synapsing with cells in the posterior gray column, including the aforementioned substantia gelatinosa. At these synapses, specific neurotransmitters are at play. Substance P, a peptide, is thought to be a key neurotransmitter, known for its slow release and widespread diffusion, contributing to the prolonged nature of some pain.
Substance P, slow, widespread pain signal.
Glutamate, an amino acid, is also released by both A and C fibers. It's fast-acting and more localized, contributing to rapid pain transmission.
Glutamate fast, localized. So the second-order neurons, which arise from these cells in the posterior gray column, particularly from the substantia gelatinosa, then take a critical hallmark step. Their axons cross very obliquely to the opposite side of the spinal cord.
Cross obliquely. Okay.
This decussation occurs in the anterior gray and white commissures, typically within just one spinal segment from their entry point. Once they've crossed, these fibers ascend in the contralateral opposite side white column as the lateral spinothalamic tract.
Lateral spinothalamic tract cross pain and temperature pathway.
As this tract continues its ascent through the spinal cord, new fibers carrying information from higher spinal segments are continuously added to its anteromedial aspect. This results in a precise lamination.
Lamination, like layers.
Exactly. In the upper cervical cord, sacral fibers carrying sensation from the lower body are positioned more laterally, while cervical fibers from the upper body are more medial.
So feet outside, neck inside, basically.
Pretty much. Interestingly, within this tract, pain fibers are positioned slightly anterior to temperature fibers.
As the lateral spinothalamic tract continues its journey through the brainstem, specifically the medulla oblongata, pons, and midbrain, it is joined by the anterior spinothalamic tract and the spinotectal tract. Together, these three tracts form a collective, compact bundle known as the spinal lemniscus.
Spinal lemniscus, the combined bundle in the brainstem.
Many of the fibers within the spinal lemniscus then terminate by synapsing with third-order neurons in the ventral posterolateral nucleus of the thalamus.
VPL nucleus of the thalamus, still the relay station.
It is widely believed that crude, basic pain and temperature sensations, along with the initiation of initial emotional reactions to these sensations, are processed and appreciated at this thalamic level.
So basic feeling happens in the thalamus.
Seems likely, yeah. Crude awareness.
From the thalamus, the third-order axons embark on their final leg of the journey, passing through the posterior limb of the internal capsule and the corona radiata, a fan-shaped arrangement of nerve fibers, to finally reach the substhetic area in the postcentral gyrus of the cerebral cortex.
Postcentral gyrus, the primary sensory cortex.
Here, in the primary sensory cortex, the contralateral half of the body is meticulously represented in an inverted fashion. The hand and mouth regions are situated inferiorly, the leg superiorly, and the foot and anogenital regions are represented on the medial surface of the cerebral hemisphere.
The sensory homunculus. Little man upside down.
That's the one. It's at this cortical level that the quality, the precise characteristics, and the refined interpretation of this sensory information at a conscious level truly occur.
Pain perception itself is an incredibly complex, multifaceted phenomenon, influenced not just by the raw physical stimulus, but profoundly shaped by our emotional state, our cognitive attention, and our past experiences.
It's not just about the signal, it's how we interpret it.
Exactly. Fundamentally, it serves as a vital, often unpleasant, warning system, alerting us to potential tissue injury or damage. We generally differentiate between two main types of pain. Fast pain, which is described as sharp, acute, or pricking.
Fast pain, sharp, quick.
This pain is experienced rapidly, within approximately 0.1 seconds, is mostly confined to the skin, and is typically elicited by mechanical or thermal stimuli. It's usually precisely localized. These fast fibers are thought to stimulate second-order neurons of the lateral spinothalamic tract relatively directly.
Okay.
In contrast, slow pain is described as burning, aching, or throbbing. This sensation is felt later, typically after 1.0 seconds or more, is produced by tissue destruction, can occur in any body tissue, and is elicited by mechanical, thermal, or chemical stimuli.
Slow pain, burning, aching, later onset.
Crucially, slow pain is often poorly localized and spreads over diffuse areas. Most slow pain fibers involve additional, often polysynaptic, relays within the posterior horn before their signals ascend. Furthermore, repeated noxious stimuli, specifically transmitted via C fibers, can lead to a phenomenon known as winding up.
Winding up, what's that?
An increased and prolonged response of second-order neurons due to sustained glutamate release. Essentially, the system becomes hypersensitive.
Ah, okay, like chronic pain amplification. What's truly fascinating here is that while fast pain impulses ascend quite directly through the thalamus to the cerebral cortex for precise localization, the majority of slow pain fibers within the lateral spinothalamic tract actually terminate in the reticular formation of the brainstem.
So slow pain goes to the reticular formation too, not just the thalamus.
A lot of it does, yes. This extensive network then plays a key role in activating the entire nervous system, contributing to our broader, often generalized, awareness of chronic suffering.
That's why chronic pain can feel so pervasive and affect everything.
Exactly. Advanced imaging techniques such as positron emission tomography, PET scans, have revealed that multiple brain regions are concerned with nociceptive pain information. The postcentral gyrus, involved in interpreting pain in relation to past experiences. The cingulate gyrus, part of the limbic system, heavily involved in the emotional aspect of pain.
Cingulate the emotional component.
And the insular gyrus, which processes pain from internal organs and contributes to autonomic responses.
And this raises a profound and clinically vital question. Can we truly modulate or even control pain?
Can we?
The answer is a resounding yes. The reception and processing of pain information by the central nervous system is dynamically modulated at various levels, beginning right in the posterior gray horns of the spinal cord and continuing at higher brain centers.
So we have built-in pain control.
We do. Historically, and even in modern complementary medicine, methods like massage, liniments, acupuncture, and low-frequency electrical stimulation are known to provide pain relief. One theory, the gating theory, proposed that at the pain fiber entry point into the CNS, inhibition occurs via specialized connector neurons that are excited by large, myelinated, non-painful touch and pressure fibers, effectively closing the gate to pain signals.
So rubbing a bumped elbow actually does something neurologically.
That's the idea behind the gate theory, yes. The touch signals kind of crowd out the pain signals at the gate. While this provides a partial explanation, the body's own powerful analgesia system is a far more comprehensive and robust mechanism.
This endogenous analgesia system is truly one of the most remarkable discoveries in neuroscience. Stimulation of specific, discrete brainstem areas, such as the periventricular area of the diencephalon, the periaqueductal gray matter of the midbrain, and certain midline nuclei, has been shown to dramatically reduce or even block pain sensations.
While stimulating parts of the brainstem can block pain.
Yes. Nerve fibers from this intricate system, believed to be part of the reticulospinal tract, descend directly to the posterior gray column of the spinal cord, where they actively suppress the transmission of both sharp and burning pain signals.
Descending pathways that inhibit pain.
And here's another key aha moment for mastering this topic. The primary neurotransmitters involved in this powerful pain-inhibiting system include enkephalin and endorphin, both endogenous opioid peptides with morphine-like action.
Endorphins are natural painkillers.
Exactly, along with serotonin. These crucial substances work by inhibiting the release of substance P from the primary afferent pain fibers in the posterior gray column, effectively dampening or even silencing the pain signal at its earliest spinal processing stage.
So they stop the pain signal right at the source synapse. Now, let's shift our focus to the pathways for light or crude touch and pressure, which primarily ascend via the anterior spinothalamic tract.
Okay, anterior spinothalamic for light touch and pressure.
The receptors for these sensations are, again, largely free nerve endings, similar to those for pain and temperature. The first-order neurons, originating from the posterior root ganglion, enter the spinal cord and are believed to synapse with cells in the substantia gelatinosa and other nuclei within the posterior gray column.
Similar start to pain temp.
Yes, but the trajectory of their second-order axons is distinct. These axons cross very obliquely to the opposite side of the cord, specifically traversing the anterior gray and white commissures. But notably, they do so over several spinal segments as they ascend.
Several segments. That's different from pain temp crossing in one segment.
It is. Once crossed, they continue their ascent in the contralateral anterolateral white column as the anterior spinothalamic tract.
Similar to the lateral spinothalamic tract, as the anterior spinothalamic tract ascends through the spinal cord, new fibers carrying information from higher segments are progressively added to its medial aspect.
Same lamination pattern, feet lateral, neck medial.
This means that in the upper cord, sacral fibers are positioned laterally and cervical segments are medial. This tract then accompanies the lateral spinothalamic and spinotectal tracts, collectively forming the spinal lemniscus as it continues its ascent through the medulla oblongata, pons, and midbrain.
Joins the spinal lemniscus too.
These fibers ultimately terminate by synapsing on third-order neurons in the ventral posterolateral nucleus of the thalamus. It's at this thalamic level that a crude, non-discriminative awareness of touch and pressure is believed to be appreciated.
Crude awareness again in the thalamus.
From there, third-order axons pass through the posterior limb of the internal capsule and corona radiata to reach the sympathetic area in the postcentral gyrus of the cerebral cortex. While conscious appreciation occurs here, the localization of light touch and pressure remains relatively crude, and our ability to discriminate intensity differences is quite limited compared to discriminative touch.
So you feel it, but you don't know exactly where or how intense it is compared to other types of touch. Next, we move to the exquisite pathways for discriminative touch, vibratory sense, and conscious muscle joint sense.
Okay, the fine-tuned stuff.
These highly refined sensations are conveyed primarily by the posterior white column, specifically within two major bundles, the fasciculus gracilis and the fasciculus cuneatus.
Posterior columns, gracilis and cuneatus.
The receptors involved in these senses are highly specialized and diverse, including Meissner corpuscles for light touch discrimination, Pacinian corpuscles for vibratory sense, and muscle spindles, and tendon organs for muscle and joint sense.
Specialized receptors for specialized senses.
The first-order axons from their cell bodies in the posterior root ganglion enter the spinal cord and, critically, pass directly to the posterior white column of the same side, ipsilaterally, meaning they do not cross at the spinal cord level.
Ah, big difference. These ones don't cross in the cord. They stay on the same side.
Exactly. That's a crucial point.
Once in the posterior white column, these fibers undergo further organization. They divide into long ascending and shorter descending branches. The short descending fibers are primarily involved in crucial intersegmental reflexes, providing local communication within the cord.
Local reflexes again.
However, many of the long ascending fibers travel extensively upwards in two distinct organized bundles. The fasciculus gracilis is present throughout the entire length of the spinal cord and contains long ascending fibers originating from the sacral, lumbar, and lower sixth thoracic spinal nerves, essentially the lower body.
Gracilis, graceful legs. Lower body info. Medial.
That's a good way to remember it. Yes, it's medial. The fasciculus cunatus, in contrast, is located more laterally within the posterior white column, appearing only in the upper thoracic and cervical segments. It carries long ascending fibers from the upper sixth thoracic and all cervical spinal nerves, essentially the upper body.
Cuneatus, wedge-shaped. Upper body info. Lateral.
A septum separates these two fasciculi in the cervical region.
These fibers, from both the fasciculus gracilis and fasciculus cuneatus, ascend ipsilaterally on the same side of the body they entered, all the way up to the medulla oblongata in the brainstem.
Still ipsilateral, all the way to the medulla.
There, they terminate by synapsing on second-order neurons located in specific nuclei, the nucleus gracilis and nucleus cuneatus, respectively. Now, here's a pivotal moment, a truly critical crossover point for conscious sensation. The axons of these second-order neurons, now called internal arcuate fibers, sweep dramatically anteromedially.
Internal arcuate fibers.
They then cross the median plane, a profound decussation known as the sensory decussation.
Sensory decussation. So these pathways cross way up high in the medulla, not in the spinal cord.
Precisely. Once crossed, they ascend as a single, highly compact and organized bundle, the medial lemniscus, which travels through the medulla oblongata, pons, and midbrain.
Medial lemniscus, the crossed pathway going up through the brainstem. These medial lemniscus fibers then terminate by synapsing on third-order neurons in the ventral posterolateral nucleus of the thalamus.
Back to the VPL nucleus in the thalamus again.
Finally, the third-order axons from the thalamus pass through the posterior limb of the internal capsule and the corona radiata to ultimately reach the sympathetic area in the post-central gyrus of the cerebral cortex. It is at this highest level of cortical processing that the most refined aspects of sensation are appreciated. Fine gradations of intensity, exact localization of touch, the ability to distinguish two separate points of touch, two-point discrimination, the nuanced vibratory sense, and our conscious recognition of our body's precise position and movement in space, all the highly detailed GPS information for our body.
So the posterior column's medial lemniscus system is for all that fine detailed sensory information. Interestingly, even within this system, there's a specialized detour for unconscious proprioception directly to the cerebellum.
Unconscious again, like we saw with Clark's column.
Exactly. Many fibers from the fasciculus cuneatus, specifically those from the cervical and upper thoracic segments, carrying upper body proprioceptive information after synapsing on second-order neurons in the nucleus cuneatus, diverge. Their axons, now called posterior external arcuate fibers, then travel to enter the cerebellum directly through the inferior cerebellar peduncle of the same side.
So some cuneatus info takes a shortcut to the cerebellum, staying on the same side.
Yes, these fibers convey muscle joint sense, but it's unconscious information, meaning it bypasses the cerebral cortex entirely. It's used by the cerebellum for its critical role in coordination without us being consciously aware of every microadjustment.
This brings us to other vital pathways that funnel muscle joint sense directly to the cerebellum for unconscious coordination, essential for balance, posture, and fluid movement. First, the posterior spinocerebellar tract.
Posterior spinocerebellar going to the cerebellum.
The first-order axons, entering the spinal cord from the posterior root ganglion, synapse on second-order neurons located specifically in the nucleus dorsalis, or Clark column, which, as we remember, extends from the C8 spinal segment caudally to the L3-L4 segments.
Back to Clark's column.
The axons of the second-order neurons then enter the posterolateral part of the lateral white column on the same side, ipsilaterally, and ascend as the posterior spinocerebellar tract.
Ipsilateral again. Stays on the same side.
This tract ascends all the way to the medulla oblongata, where it joins the inferior cerebellar peduncle and ultimately terminates in the cerebellar cortex. Crucially, it does not ascend to the cerebral cortex because it carries only unconscious proprioceptive information.
Inferior cerebellar peduncle to the cerebellum. Unconscious. Okay.
Its primary function is to receive detailed muscle joint information from muscle spindles, tendon organs, and joint receptors of the trunk and lower limbs. This information is then used by the cerebellum for its sophisticated role in the coordination of limb movements and the continuous maintenance of posture.
Then there's the anterior spinocerebellar tract, which has a more complex trajectory. First-order axons from the posterior root ganglion also synapse with second-order neurons in the nucleus dorsalis.
Starting at Clark's column again.
However, a significant majority of these second-order axons cross to the opposite side of the spinal cord and ascend as the anterior spinocerebellar tract in the contralateral lateral white column.
Wait, this spinocerebellar tract crosses?
Most of it does, yes, although a minority do ascend ipsilaterally. These fibers ascend through the medulla oblongata and pons, but unlike the posterior tract, they enter the cerebellum through the superior cerebellar peduncle.
Superior cerebellar peduncle this time, and it crossed, mostly.
And here's a particularly fascinating nuance. Those fibers that crossed over in the spinal cord are believed to cross back again within the cerebellum itself, ultimately terminating in the cerebellar cortex.
A double cross. Crosses in the cord, then crosses back in the cerebellum.
Why? That's a great question. The functional significance is still debated, but it ultimately means the information ends up coordinating the side it originated from. This tract conveys muscle joint information from muscle spindles, tendon organs, and joint receptors, not just from the trunk, but also from both the upper and lower limbs. It's also thought to receive information from the skin and superficial fascia, contributing to a broader sense of body awareness for cerebellar coordination.
Beyond these major sensory highways, the spinal cord also houses other specialized ascending pathways, each with unique roles. The spinotectal tract, for instance, provides crucial sensory information specifically for spinovidual reflexes.
Spinovidual reflexes, like turning towards something you see.
Exactly. This means it helps to bring about rapid automatic movements of our eyes and head toward the source of a startling or significant visual stimulation. The pathway involves axons from unknown second-order neurons in the gray matter that cross the median plane and ascend in the anterolateral white column, typically running close to the lateral spinothalamic tract. They terminate on neurons in the superior colliculus of the midbrain, a key center for visual reflexes.
Spinotectal crosses goes to superior colliculus for visual reflexes.
Got it.
Next, the spinoreticcular tract provides an essential afferent pathway for the reticular formation in the brainstem.
Back to the reticular formation for arousal.
Exactly. This reticular formation plays an incredibly important role in influencing our overall levels of consciousness and wakefulness, acting as a kind of master switch for arousal. Most of the fibers in this tract are uncrossed, meaning they remain on the same side they entered and ascend in the lateral white column, often intermingled with the lateral spinothalamic tract. They terminate on neurons of the reticular formation located throughout the medulla oblongata, pons, and midbrain.
Spinoreticular mostly uncrossed, to reticular formation for wakefulness. And then there's the spino-olivary tract, which, while perhaps less direct, provides an important indirect pathway for further afferent information to reach the cerebellum from both cutaneous, skin, and proprioceptive body position organs.
Spino-olivary, to the olive, then cerebellum, another cerebellar pathway.
Seems so. The axons from posterior root ganglion cells synapse on unknown second-order neurons in the posterior gray column. These second-order axons then cross the midline and ascend in the white matter, specifically at the junction of the anterior and lateral columns. They terminate on third-order neurons located in the inferior olivary nuclei within the medulla oblongata.
Okay, crosses goes to inferior olive.
Crucially, the axons of these third-order neurons then cross the midline again, performing a second decussation before entering the cerebellum through the inferior cerebellar peduncle.
Another double cross, just like the anterior spinocerebellar. Crosses, goes to olive, crosses again, then to cerebellum. Very complex routing.
It really highlights the intricate redundancy and complexity of cerebellar input.
Finally, we must consider the visceral sensory tracts, which serve as our body's essential internal monitors, conveying sensations from our internal organs. Sensations originating from the viscera in the thorax and abdomen enter the spinal cord through the posterior roots, with their first-order cell bodies located in the posterior root ganglia.
Sensing the insides.
Their peripheral processes are connected to specialized receptors within the viscera, which are highly sensitive to various stimuli, including pain and stretch. Common causes of visceral pain include ischemia, lack of blood flow, chemical damage, spasm of smooth muscle, and distension of hollow organs. Once these central processes enter the spinal cord, they synapse with second-order neurons in the gray matter, most likely within the posterior or lateral gray columns.
The axons of these second-order neurons are believed to largely join the spinothalamic tracts, the same pathways that carry somatic pain and temperature.
So visceral pain travels with regular pain temp signals.
Largely, yes. They then ascend to terminate on third-order neurons in the ventral posterolateral nucleus of the thalamus. From the thalamus, their final destination is likely the postcentral gyrus of the cerebral cortex, where conscious, albeit poorly localized, awareness of visceral sensation occurs.
Poorly localized awareness. That makes sense for organ pain.
It's important to remember that many visceral afferent fibers also branch extensively to participate in reflex activity, mediating crucial autonomic responses. Clinically, visceral pain is characteristically poorly localized, often described as a diffuse ache or pressure, and is frequently associated with profound autonomic responses, such as salivation, nausea, vomiting, changes in heart rate, tachycardia or bradycardia, and sweating. And perhaps most famously, this is the phenomenon where we encounter referred pain.
Referred pain, right, like heart attack pain felt in the left arm.
Exactly, where pain originating from an internal organ is felt paradoxically in a distant area of the body surface. 4. The descending commands, orchestrating movement.
If the ascending tracts are the intricate highways meticulously bringing sensation to consciousness, then the descending tracts are the master conductors, the powerful command and control pathways orchestrating every nuanced movement of our bodies.
Okay, switching directions now. Going down.
At the very lowest level of this motor hierarchy are the lower motor neurons. These vital nerve cells have their cell bodies strategically located within the anterior gray columns of the spinal cord.
Lower motor neurons in the anterior horn.
Their axons then exit the spinal cord, passing through the anterior roots of the spinal nerves to directly innervate our skeletal muscles. They are aptly termed the final common pathway to the muscles, because every voluntary and involuntary command must ultimately pass through these neurons to elicit muscle contraction.
Final common pathway. All roads lead here for movement.
Precisely.
And these lower motor neurons are not operating in isolation. They are constantly bombarded by an immense barrage of impulses. These impulses originate from two primary sources, both from higher centers in the brain, including the medulla, pons, midbrain, and the cerebral cortex, and directly from sensory fibers entering the spinal cord via the posterior roots, mediating reflex activity.
So they're getting input from above and from local reflexes.
The nerve fibers that descend from these higher supraspinal nerve centers are meticulously segregated into specific bundles within the white matter, known as the descending tracts. These supraspinal neurons and their tracts are collectively referred to as the upper motor neurons.
Upper motor neurons, the ones coming down from the brain.
And they provide numerous distinct pathways that intricately influence the activity of the lower motor neurons, thereby controlling our vast repertoire of motor activity.
The anatomical organization for motor control, originated from the cerebral cortex, typically involves a multi-neuron descending pathway. The first-order neuron has its cell body in the cerebral cortex itself, usually in the motor areas.
First order starts in the cortex.
Its long axon descends, often traversing significant distances, to synapse on a second-order neuron. This second-order neuron is typically an internuntial neuron or interneuron, strategically situated within the anterior gray column of the spinal cord.
Second order, usually an interneuron in the cord.
Its axon is characteristically short and forms a synapse with the third-order neuron, which is, crucially, the lower motor neuron in the anterior gray column. The axon of this lower motor neuron then exits the spinal cord to directly innervate the skeletal muscle through the anterior root and spinal nerve.
Third order, the lower motor neuron itself going to the muscle.
However, it's important to note that in some highly specialized instances, the axon of the first-order neuron can terminate directly on the third-order neuron, the lower motor neuron, bypassing the interneuron.
Direct connection sometimes.
Yes, as is seen in certain rapid reflex arcs, allowing for immediate, unmodulated responses.
The absolute master conductors of our voluntary movement, particularly those requiring exquisite precision and skill, are the corticospinal tracts, famously known as the pyramidal tracts.
The corticospinal tracts, the big one for voluntary movement.
These are the primary pathways concerned with initiating and executing voluntary, discrete, and highly skilled movements, especially those involving the distal parts of our limbs, like the intricate dexterity of our fingers for writing or playing an instrument.
Distal limbs, hands and feet dexterity.
The fibers of these powerful tracts arise as axons from spiralized pyramidal cells, specifically the large BET cells located predominantly in the fifth layer of the cerebral cortex. Roughly 1/3 of these fibers originate from the primary motor cortex, Brodmann Area 4,
Primary motor cortex area 4.
a major command center for movement. Another third comes from the secondary motor cortex, Brodmann Area 6, involved in planning and coordinating movements.
Secondary motor area 6, planning.
The final third originates from the parietal lobe, Brodmann Areas 3, 1, and 2, which are primarily sensory areas. It's important to understand that these parietal fibers do not directly control motor activity, but rather significantly influence sensory input to the nervous system, modulating perception during movement.
So some fibers come from sensory cortex to modulate. Interesting. We can conceptually visualize the precise representation of the body within the primary motor cortex through what is famously known as the motor homunculus.
The motor homunculus now, similar to the sensory one?
Very similar concept. Electrical stimulation of different parts of the precentral gyrus, where the primary motor cortex resides, reliably produces movements of different parts of the opposite side of the body. The homunculus is a distorted, almost grotesque human figure overlaid on the cortex, where the size of each body part is proportional to the cortical area devoted to its control, not its actual physical size.
So big hands, big face on the homunculus again.
Exactly. For example, the face and hands, which require incredibly precise and fine motor control, occupy a disproportionately large area inferiorly, while the lower limb is situated superiorly and on the medial surface of the hemisphere. It's a vivid illustration of the brain's dedication to dexterity. It's also worth noting that most corticospinal fibers, while crucial, are myelinated, relatively slow conducting, and surprisingly small in diameter compared to some other fibers.
Now let's meticulously trace their long, arduous, and clinically significant descent from the cerebral cortex. Initially, these millions of descending fibers converge dramatically within the corona radiata, a large fan-shaped collection of nerve fibers.
Corona radiata fanning out from the cortex.
From there, they funnel through the posterior limb of the internal capsule, a critical, narrow choke point deep within the brain. Within this internal capsule, the fibers are highly organized. Those destined for the cervical portions of the body are situated more medially, while those for the lower extremity are located more posteriorly.
Internal capsule organized choke point. Arm medial, leg posterior.
They then continue their descent, passing through the middle 3/5 of the basis pedunculi, the large anterior portion of the midbrain, maintaining a similar medial to lateral organization for cervical and leg fibers, respectively.
Basis pedunculi in the midbrain. Still organized. Upon entering the pons, the corticospinal tract, which was a compact bundle, becomes temporarily broken up into many smaller, discrete bundles by the transverse pontocerebellar fibers that cross its path.
Scattered in the pons.
As they continue into the medulla oblongata, these bundles regroup along the anterior border, forming a prominent, visible swelling known as the pyramid on the ventral surface of the medulla, hence the name pyramidal tract.
Ah, the pyramids of the medulla. That's where the name comes from.
Exactly. And here we encounter one of the most clinically critical and fundamental crossover points in the entire nervous system. At the very junction of the medulla oblongata and the spinal cord, a vast majority of these fibers, typically an astonishing 75% to 90%, perform a profound crossing of the midline, an event known as the decussation of the pyramids.
The decussation of the pyramids. So this major motor pathway crosses low down at the medulla-spinal cord junction.
Precisely. A massive crossover point.
These now crossed fibers, representing the vast majority of the corticospinal pathway, then enter the lateral white column of the spinal cord to form the lateral corticospinal tract.
Lateral corticospinal tract, the main crossed pathway.
This powerful tract descends the entire length of the spinal cord, terminating by synapsing extensively in the anterior gray column of all spinal cord segments. This is the primary pathway for fine, skilled, voluntary movements of the opposite side of the body.
Controls the opposite side.
The remaining fibers, a smaller contingent of about 10% to 25%, do not cross in the decussation, but instead descend ipsilaterally in the anterior white column of the spinal cord, forming the anterior corticospinal tract.
Anterior corticospinal tract smaller, uncrossed initially.
These fibers eventually do cross the midline, but they do so only at their specific level of destination within the anterior white commissure. terminating in the anterior gray column, primarily in the cervical and upper thoracic regions. This bilateral innervation, particularly strong in the neck and trunk, provides a crucial redundancy.
So the anterior ones cross later, at the level they act, mostly for trunk necks. When it comes to their termination and ultimate function, most corticospinal fibers do not directly synapse on lower motor neurons. Instead, they primarily synapse with internuntial neurons, inner neurons, located within the gray matter.
Synapsing on inner neurons, mostly.
Yes, which then in turn synapse with both alpha and some gamma motor neurons. Only the very largest corticospinal fibers, those responsible for the most precise and powerful movements, synapse directly with motor neurons, allowing for rapid, unmodulated control.
Only the biggest ones connect directly.
It is absolutely crucial to understand that while the corticospinal tracts are paramount for our vast repertoire of voluntary movements, they are not the sole pathway for such activity. Their unique contribution is conferring remarkable speed and agility to movements, especially those requiring high levels of skill.
Speed and agility, that's their specialty.
Like playing a musical instrument, performing intricate surgical tasks, or delicate finger work. Many simple, basic voluntary movements are, in fact, mediated by other descending tracts, demonstrating the complex, redundant nature of motor control.
So other tracts handle the basic stuff.
Largely, yes. The corticospinal adds the finesse.
And these powerful tracts are not merely one-way conduits. They give off numerous collateral branches early in their descent. Some of these branches return to the cerebral cortex itself, playing a role in inhibiting activity in adjacent cortical regions, thus sharpening the motor command.
Feedback loops even back to the cortex.
Other crucial branches pass to important subcortical nuclei, including the caudate and lentiform nuclei, part of the basal ganglia, the red nuclei, the olivary nuclei, and the reticular formation. This extensive branching ensures that these vital subcortical regions are kept continuously and precisely informed about cortical motor activity,
Keeping everyone in the loop.
allowing them to react, modulate, and send their own impulses to alpha and gamma motor neurons via other parallel descending pathways. This creates a deeply integrated, multi-layered control system for movement.
Beyond the direct corticospinal tracts, we have other incredibly influential descending tracts, which are often collectively and somewhat imprecisely grouped under the extrapyramidal system, a term that largely refers to their non-pyramidal origin and trajectory in the medulla.
Okay, the extrapyramidal tracts, what are they?
Foremost among these are the reticulospinal tracts. These tracts originate from the reticular formation, which is not a single nucleus, but a diffuse, complex network of scattered nerve cells and fibers found throughout the entire midbrain, pons, and medulla oblongata.
Reticular formation again, it does a lot.
It really does. Specifically, from the pons, the pontine reticulospinal tract arises, with most of its neurons sending axons that are largely uncrossed and descend to the spinal cord in the anterior white column. From the medulla, similar neurons send axons, which are both crossed and uncrossed, to the spinal cord, forming the medullary reticulospinal tract, descending primarily in the lateral white column.
Pontine mostly uncrossed, medullary mixed. What's truly fascinating about these reticulospinal tracts is their complex and often opposing roles. They may both facilitate or inhibit the activity of alpha and gamma motor neurons in the anterior gray columns.
Facilitate and inhibit, so they can turn movement up or down.
Exactly. This means they exert a profound influence over both voluntary movement and reflex activity, providing a dynamic fine-tuning mechanism. Beyond their role in somatic motor control, the reticulospinal fibers are now widely thought to also include crucial descending autonomic fibers.
Autonomic control again, like we suspected with the lateral horn.
This provides a vital pathway by which higher brain centers, particularly the hypothalamus, can exert direct control over the sympathetic outflow, our fight or flight responses, and the sacral parasympathetic outflow, our rest and digest functions, integrating bodily functions with our overall state.
The tectospinal tract is another important pathway, originating from nerve cells located in the superior colliculus of the midbrain. This midbrain structure is a key center for visual reflexes.
Tectospinal from superior colliculus, visual center.
A critical feature of this tract is that most of its fibers cross the midline very soon after their origin, decussating within the midbrain. They then descend through the brainstem, running in close proximity to the medial longitudinal fasciculus, a brainstem pathway for coordinating eye movements. This tract descends primarily through the anterior white column of the spinal cord and largely terminates in the anterior gray column, but almost exclusively in the upper cervical segments, synapsing with internuncial neurons.
Crosses high, goes to upper neck region. Why?
Its primary function is unequivocally concerned with reflex postural movements in response to visual stimuli. For example, it mediates the rapid, involuntary turning of the head and eyes towards a sudden flash of light or a movement in our peripheral vision. It's also involved in the pupillodilation reflex, causing the pupils to widen in response to darkness via sympathetic neurons in the lateral gray column.
Turning your head towards a sound or light automatically. Then there's the rubrospinal tract, originating from the red nucleus, a prominent ovoid mass of gray matter situated in the tegmentum of the midbrain, precisely at the level of the superior colliculus.
Rubrospinal from the red nucleus.
The axons from this nucleus, much like the tectospinal tract, undergo a crucial crossing of the midline immediately at the level of their origin, known as the ventral tegmental decussation.
Crosses high as well.
Once crossed, these fibers descend through the pons and medulla oblongata to enter the lateral white column of the spinal cord. These fibers primarily terminate by synapsing with internuncial neurons in the anterior gray column of the cord.
Lateral column again. What's its job?
Functionally, the red nucleus receives significant afferent impulses from both the cerebral cortex via the corticocerebral pathway and the cerebellum via the cerebellocerebral pathway. Consequently, the rubrospinal tract is believed to be an important indirect pathway through which both the cerebral cortex and the cerebellum can significantly influence alpha and gamma motor neuron activity.
Indirect control from cortex and cerebellum.
More specifically, it is thought to facilitate the activity of flexor muscles and, conversely, to inhibit the activity of extensor or anti-gravity muscles, particularly in the upper limb, contributing to arm and hand movements.
Facilitates flexors, inhibits extensors, especially arms. Okay, the vestibulospinal tract is critically involved in maintaining balance and posture. It rises from the vestibular nuclei, a complex of 4 nuclei situated in the pons of medulla oblongata, just beneath the floor of the fourth ventricle.
Vestibulospinal from vestibular nuclei balance center.
These nuclei receive crucial afferent fibers from the inner ear via the vestibular nerve, providing continuous information about head position and movement, as well as significant input from the cerebellum, which integrates balance information. The fibers that form the vestibulospinal tract primarily arise from the lateral vestibular nucleus. A key characteristic of this tract is that it descends uncrossed, meaning it remains on the same side it originated.
Uncrossed. Stays ipsilateral all the way down.
Through the medulla and extends the entire length of the spinal cord in the anterior white column. It primarily terminates by synapsing with internuncial neurons in the anterior gray column. Through its direct connections with the inner ear and cerebellum, this tract plays an essential role in mediating postural adjustments. It profoundly facilitates the activity of extensor muscles, our anti-gravity muscles, and inhibits the activity of flexor muscles.
Opposite of rubrospinal. Facilitates extensors, inhibits flexors.
Exactly, which is absolutely crucial for maintaining our postural activity associated with balance in response to changes in head and body position, keeping us upright.
There's also the olivosspinal tract, though its very existence as a distinct organized pathway in humans is considerably doubted by many neurologists and neuroanatomists.
Olivosspinal maybe doesn't exist.
Okay.
Good to know.
If it were to exist, it would theoretically arise from the inferior olivary nucleus in the medulla and descend in the lateral white column of the spinal cord, ultimately influencing motor neuron activity. But for advanced understanding, it's important to recognize that its presence as a dedicated tract is still debated.
Fair enough. Finally, we must acknowledge the crucial descending autonomic fibers. While distinct, anatomically well-defined tracts for these fibers have not been formally recognized in the same way as, say, the corticospinal tract, extensive investigations of spinal cord lesions and clinical observations unequivocally confirm their existence and profound importance.
So we know they're there, even if we can't point to a single autonomic tract.
Right. They are widely believed to form an integral part of the reticulospinal tract, essentially traveling within this broader pathway. These fibers originate from higher central nervous system centers that exert control over autonomic activity, such as the cerebral cortex, the hypothalamus, a master regulator of autonomic function, the amygdaloid complex involved in emotional responses, and the reticular formation itself.
Coming from high-level control centers.
They're thought to cross the midline in the brainstem and then descend within the lateral white column of the spinal cord. Their ultimate destination is to synapse on the preganglionic autonomic motor cells located in the lateral gray columns. Specifically, at the thoracic and upper lumbar levels, T1, L2, L3, for sympathetic outflow, and at the mid-sacral levels, S2, S4, for parasympathetic outflow, thus controlling vital involuntary bodily functions.
Synapsing on those autonomic neurons in the lateral horns we talked about earlier, it all connects. V-intersegmental connections and the reflex arc. So we've navigated the long-distance highways of the spinal cord, the ascending sensory pathways carrying information up to the brain, and the descending motor commands traveling down. But what about the crucial, intricate local communication within the spinal cord itself?
The local network.
That's precisely where intersegmental tracts come into play. These are defined as relatively short ascending and descending tracts that both originate and terminate entirely within the spinal cord. You'll find them distributed throughout all three white columns: the anterior, lateral, and posterior.
Their primary indispensable function is to intricately interconnect neurons of different segmental levels of the spinal cord. This robust local communication is particularly vital in mediating complex intersegmental spinal reflexes.
Okay, reflexes involving multiple cord levels.
These reflexes allow for highly coordinated and often widespread responses across multiple segments of the spinal cord, frequently without necessarily involving higher brain centers directly for every single step of the processing. They're the local switchboards of the cord.
This concept naturally leads us to the fundamental principle of the reflex arc. A reflex is simply defined as an involuntary, rapid, and predictable response to a specific stimulus, and its occurrence is entirely dependent on the structural and functional integrity of this underlying neural circuit, the reflex arc.
The basic circuit for a reflex.
In its simplest form, known as a monosynaptic reflex arc, meaning it involves only one synapse between neurons. It consists of four essential anatomical structures. First, a receptor organ located in the skin, muscle, or tendon that detects the stimulus.
Step 1, receptor.
Second, an afferent neuron, the sensory neuron, whose cell body is in the posterior root ganglion. Its central axon then enters the spinal cord and, crucially, terminates by synapsing directly on the third component.
Step 2, sensory neuron, synapses directly on.
The third component is the effector neuron, which is the lower motor neuron in the anterior gray column.
Step 3, motor neuron.
And finally, the fourth component is the effector organ, typically a skeletal muscle, which carries out the response.
Step 4, muscle. Receptor and sensory neuron, motor neuron muscle. Monosynaptic. Because of the large diameter and thus rapid conduction velocity of the afferent fibers, combined with the presence of only one synapse within the spinal cord, a very quick and immediate response is possible. Think of the knee-jerk reflex.
Right, tap the tendon, leg kicks out instantly.
However, the physiological reality is often more complex than a simple, quick monosynaptic discharge. Studies reveal that a prolonged asynchronous discharge often follows the initial rapid response.
Why is that? Why prolonged?
This occurs because the afferent fibers, upon entering the spinal cord, frequently give off numerous collateral branches. These branches don't just synapse directly, they also synapse with many internuntial neurons, or interneurons, which then in turn ultimately synapse with the effector neuron.
Ah, the interneurons add delays and loops.
Exactly. These additional neuronal circuits, involving multiple relays, serve to prolong the bombardment of the effector neurons, sustaining their activity even after the initial direct stimulation from the afferent neuron has ceased.
What's more, the very presence and extensive branching of these internuntial neurons allows the initial afferent stimulus to spread effectively to neurons located at different segmental levels of the spinal cord,
Spreading the signal up and down the cord.
This enables more complex, integrated, and widespread responses beyond just a single muscle contraction. And two key governing principles are fundamental to understanding these spinal reflexes. First, the law of reciprocal innervation.
Reciprocal innervation, what's that?
Simply put, flexor and extensor muscles acting on the same limb cannot contract simultaneously in a coordinated movement. The afferent nerve fibers initiating a scissor reflex, for example, have branches that specifically synapse with and inhibit the motor neurons supplying the extensor muscles of that very same limb.
So when you flex, the extensors relax automatically, ensures smooth movement.
Exactly. Prevents antagonist muscles from working against each other.
Second, we have the cross-extensor reflex. This is a more complex polysynaptic reflex. When a noxious afferent stimulation, say tapping on a sharp object, causes the ipsilateral limb, the limb on the same side as the stimulus, to powerfully flex and withdraw.
Pull your foot away fast.
It simultaneously and involuntarily causes the contralateral limb, the limb on the opposite side, to extend.
The other leg straightens. Why?
To support you. This provides an immediate crucial mechanism for maintaining balance and supporting the body's weight, preventing a fall when one limb is suddenly withdrawn.
Ah, clever. Flex one leg, extend the other to stay balanced. Now, while these spinal segmental reflex arcs are fundamental, it is absolutely paramount to understand that they are not isolated units. They are profoundly and continuously influenced by higher neuronal centers within the brain.
The brain is always involved, modulating things.
These sophisticated modulating influences are precisely mediated through the various descending tracts we meticulously discussed earlier: the corticospinal, reticulospinal, tectospinal, rubrospinal, and vestibulospinal tracts. These higher centers can fine-tune, facilitate, or inhibit spinal reflexes, integrating them into our complex voluntary movements and overall posture.
This brings us to a critically important clinical concept, one that every medical professional must master: spinal shock syndrome.
Spinal shock, what happens here?
This is a complex clinical condition that invariably follows acute severe damage to the spinal cord, often immediately after trauma like our patients fall. Characteristically, all cord functions below the level of the lesion become profoundly depressed or entirely lost.
Everything below the injury just shuts down.
Pretty much, yes.
Okay.
Clinically, this manifests as a complete loss of sensation and flaccid paralysis, loss of muscle tone and reflexes, in all segments below the injury. The underlying mechanism is attributed to the sudden, complete removal of the constant facilitatory, excitatory influences from those higher brain centers,
Cutting off the brain's go signals.
carried by tracts like the corticospinal and reticulospinal on the segmental spinal reflexes below the lesion. For high-level cervical lesions, spinal shock can also lead to severe hypotension due to the sudden loss of sympathetic vasomotor tone, which regulates blood vessel constriction.
How long does spinal shock last?
In the majority of patients, spinal shock is a transient phase, lasting less than 24 hours. However, in some severe cases, it can persist for as long as 1 to 4 weeks, or even occasionally longer. As the period of spinal shock gradually diminishes, the neurons below the lesion, which were initially depressed, slowly regain their excitability.
They start to wake up again.
And as they do, the characteristic effects of upper motor neuron loss, specifically the emergence of spasticity and exaggerated reflexes, begin to appear in the segments below the lesion.
Ah, so after the initial flaccid paralysis comes spasticity.
Often, yes. A key clinical test to determine the presence of spinal shock and differentiate it from a complete lesion is to check for anal sphincter reflex activity. If this reflex is absent, it indicates the patient is in spinal shock, assuming the sacral segments themselves are not directly damaged.
Once spinal shock dissipates, specific post-spinal shock outcomes can manifest, reflecting the chronic state of the lesion. One such outcome is decerebrate rigidity, where muscle tone increases significantly. This is largely due to the overactivity of the gamma-efferent nerve fibers to the muscle spindles.
The gamma motor neurons become overactive.
Yes, resulting from the release of these neurons from the inhibitory or modulatory control of higher centers. This can lead to a condition known as paraplegia in extension, where the increased tone of the extensor muscles dominates over the flexors, causing the limbs to be stiffly extended.
Paraplegia in extension limbs stiffly straight.
Some neurologists theorize this might occur with incomplete severance of descending tracts, particularly if the vestibulospinal tract, which facilitates extensors, remains more active. Conversely, if all descending tracts are completely severed, the condition can progress to paraplegia inflection, where reflex responses below the lesion become predominantly flexor in nature and extensor muscle tone significantly diminishes.
Paraplegia inflection limbs drawn up. So the pattern depends on which tracts might be spared.
That's the thinking, yes. Paraplegia in extension can indeed transition to paraplegia inflection if the cord damage becomes more extensive or complete over time.
And finally, a fascinating crucial detail in this intricate system of motor control and modulation is the role of Renshaw cells.
Renshaw cells, what do?
These are specialized internuntial neurons found within the anterior gray column. What happens is that the axons of lower motor neurons, as they exit the anterior gray column, give off small collateral branches. These collateral branches then synapse on Renshaw cells.
Motor neuron talks to Renshaw cell.
In turn, these Renshaw cells then synapse back on the very same lower motor neurons that activated them, as well as on other adjacent motor neurons.
Renshaw cell talks back to the motor neuron, a feedback loop.
Exactly. This creates a powerful feedback inhibition loop. The function of this loop is to actively regulate and fine-tune the activity of the lower motor neurons, preventing excessive or prolonged excitation and helping to ensure smooth, controlled muscle contraction. It's a precise self-regulation mechanism.
Stopping the motor neuron from firing too much. Very neat. 6. Clinical applications. Understanding spinal cord injuries and disease.
Now let's synthesize all this detailed anatomical and physiological knowledge and bring it directly into the clinical realm, exploring its immense practical importance for understanding spinal cord injuries and various neurological diseases.
Putting it all together clinically.
As we've established, the spinal cord is remarkably protected within the vertebral canal, cushioned by its 3 meningeal layers and the cerebrospinal fluid. Its position is further stabilized by the delicate yet firm denticulate ligaments on each side, which anchor the cord to the dura mater, and by the filum terminale inferiorly. It's segmented with each pair of posterior sensory and anterior motor roots, precisely leaving the vertebral canal through their respective intervertebral foramina.
But here's a crucial anatomical fact with profound clinical implications, one you absolutely must grasp to understand diagnostic procedures. The spinal cord is distinctly shorter than the vertebral column itself.
Right, the cord ends high up.
In adults, as we noted, it typically terminates at the lower border of the first lumbar vertebra, L1. However, the vertebral column extends much further caudally, and critically, the subarachnoid space, which contains the cushioning CSF, extends inferiorly well beyond the end of the spinal cord, all the way down to the lower border of the second sacral vertebra, S2.
Subarachnoid space goes down to S2, cord ends at L1. Because of this significant disparity in length between the spinal cord and the vertebral column, the nerve roots of the lumbar and sacral segments, which emerge from the lower end of the cord, must take a long, oblique downward course within the lumbar cistern to reach their corresponding intervertebral foramina lower down in the vertebral column.
They have to travel downwards inside the canal.
This unique arrangement forms a characteristic bundle of nerve roots known as the cauda equina, literally meaning horse's tail.
Ah, the cauda equina.
This anatomical difference is precisely what enables and ensures the safety of a spinal tap or lumbar puncture procedure. A needle can be safely inserted into the subarachnoid space below the L2 vertebral level, typically at the L3, L4, or L4, L5 interspaces, without risking direct damage to the spinal cord itself, as only floating nerve roots of the cauda equina are present there, which tend to move away from the needle.
So you poke below L2 to avoid hitting the cord itself. Smart. Now, let's consider the clinical vulnerabilities of the anterior and posterior nerve roots themselves. Each nerve root, as it exits the spinal cord, is enveloped by its own protective coverings of pia motor, arachnoid mater, and dura mater, continuous with the spinal meninges.
The roots have meningeal sleeves.
These meningeal coverings eventually fuse with the epineurium, the outermost connective tissue sheath, of the spinal nerves as the roots unite to form the spinal nerve within the intervertebral foramina. This anatomical location renders the roots highly susceptible to compression from various sources, such as vertebral tumors, a herniated intervertebral disc, a very common cause of nerve root pain.
Yes, slip discs pressing on roots.
Fractures of the vertebrae, or severe spinal deformities like scoliosis. Furthermore, they can be irritated by abnormal constituents within the CSF, such as blood after a subarachnoid hemorrhage, or inflammatory cells in cases of meningitis. Specific conditions like cystolytic spinal meningitis, pyogenic bacterial meningitis, Taves dorsalis, a form of neurosyphilis selectively affecting the posterior roots, and herpes zoster, shingles, can also specifically involve and damage these roots.
Lots of things can affect the roots. What are the telltale symptoms, then, of such nerve root lesions? A lesion affecting primarily one posterior spinal nerve root will classically cause pain in the specific dermatome, the distinct area of skin innervated by that particular root, and in the muscles that receive their sensory supply from that root.
Pain following a dermatome pattern.
This pain is often exacerbated or heightened by movements of the vertebral column, coughing or sneezing, all of which transiently increase the pressure within the vertebral canal and thus on the compromised nerve root.
Coughing makes the leg pain worse, classic sign.
Exactly. Before a complete overt loss of sensation in the dermatome, the patient might experience sensory abnormalities such as hyperalgesia, an increased sensitivity to painful stimuli, and hyperesthesia, an increased sensitivity to touch.
Conversely, a lesion affecting an anterior root will primarily manifest as motor deficits, This will result in paralysis, complete loss of movement of any muscle supplied exclusively by that specific root, or partial paralysis if the muscle receives only partial innervation from that root.
Anterior root lesion equals weakness or paralysis.
In both scenarios, you'll typically observe fasciculation, which are visible, spontaneous muscle twitchings. These are often a key sign, particularly with slow, ongoing destruction of the lower motor neuron.
Fasciculation's muscle twitches, LMN sign.
Ultimately, this leads to profound muscle atrophy, where the muscle wastes away due to loss of innervation. Furthermore, muscular contracture, a shortening and tightening of the paralyzed muscles, often occurs in the antagonist muscles whose action is no longer opposed by the weakened or paralyzed agonists. A key diagnostic test to confirm a lower motor neuron lesion is the reaction of degeneration.
Reaction of degeneration. How the muscle responds to electricity.
Yes, which describes the characteristic changes in a muscle's electrical response to stimulation after its innervation is cut. Typically, there is no response to ferritic, interrupted, alternating current after about 7 days, and no response to galvanic direct current after about 10 days, indicating complete denervation.
The lamination, or precise segmental organization of the ascending tracts within the white matter, is of immense clinical significance. It provides a predictable pattern of sensory loss when the spinal cord is compressed externally, such as by a tumor or disc herniation.
Okay, how the tracts are layered matters clinically.
Consider the spinothalamic tracts, the anterolateral system carrying pain, temperature, and light touch. As axons carrying sensation from lower segments, like sacral and lumbar, enter the cord, they cross and are then deflected laterally by fibers from successively higher segments as those fibers cross and join the tract.
Feet sacral fibers get pushed outwards.
This means that in the upper cord, fibers from the cervical segments are positioned medially, while fibers from the sacral segments are positioned laterally. Therefore, if there's external pressure compressing the spinal cord, it will typically affect the sacral dermatomes first, leading to an initial loss of pain and temperature sensation in the lower body, often in a saddle distribution.
External pressure hits the outside fibers first, the sacral ones for spinothalamic, saddle anesthesia.
Exactly. What's truly fascinating and diagnostically crucial is that the posterior white column, part of the medial lemniscus system carrying discriminative touch, vibration, and proprioception, has the opposite lamination.
Opposite. How so?
Axons from sacral and lumbar segments, which ascend ipsilaterally, are actually pushed medially by axons from higher segments as they enter and join the column. So, in this column, the representation from sacral to cervical segments is organized from medial to lateral.
So in posterior columns, sacral is medial, cervical is lateral, totally flipped.
This fundamental difference in organization between the spinothalamic tracts and the posterior white columns leads to distinct and often contrasting patterns of sensory loss, depending on the precise location and nature of the spinal cord compression. Mastering these lamination patterns is essential for neurological localization.
Okay, so knowing the lamination helps pinpoint the lesion. Let's consider specific injury manifestations based on ascending tract damage. Destruction of the lateral spinothalamic tract at a given level will produce a profound contralateral loss of pain and thermal sensibilities.
Contralateral pain loss below the lesion.
Below the level of the lesion. This means if the lesion is on the right side of the cord, the patient will not respond to a pinprick or recognize hot and cold objects on the left side of their body below the injury. If the anterior spinothalamic tract is destroyed, it leads to a contralateral loss of light touch and pressure sensibilities below the lesion.
Contralateral light touch pressure loss.
However, it's absolutely crucial to remember that discriminative touch remains present because that specific type of touch information is conducted via the fasciculus gracilis and cuneatus in the unaffected posterior white column.
But fine touch is spared because posterior columns are okay.
Good point. And if the fasciculus gracilis and cuneatus themselves are destroyed, the patient will suffer an ipsilateral loss of information from muscles and joints to consciousness below the level of the lesion.
Ipsilateral loss of proprioception. Can't tell where their limb is without looking. Right. This means they won't know the precise position or movement of their limb with their eyes closed, leading to a profound impairment in muscular control, often manifesting as movements that are clumsy, jerky, or ataxic, lacking coordination. There will also be an ipsilateral loss of vibratory sense below the lesion, meaning they cannot feel a vibrating tuning fork.
Ipsilateral vibration loss, too.
And crucially, tactile discrimination, the ability to discern fine details of touch, such as two-point discrimination or recognizing objects by feel, stereognosis, will be lost on the side of the lesion. even though general light touch might remain unaffected due to its transmission via the anterior spinothalamic tracts.
Ipsilateral loss of fine touch discrimination, but light touch might be okay. A vital caveat here. In clinical reality, spinal cord lesions rarely affect only one isolated sensory tract. Usually, several ascending and descending tracts are involved to varying degrees, leading to more complex and mixed neurological deficits.
It's rarely neat and tidy in real patients. When delving into pain, it's particularly useful to draw a clear distinction between somatic pain and visceral pain. Somatic pain, which we've extensively discussed, arises from naked nerve endings in the skin, muscles, joints, and bones. It's categorized into an initial sharp, well-localized pain transmitted by fast-conducting A fibers, followed by a prolonged, burning, aching pain conveyed by slow-conducting C fibers.
Somatic pain from body structures, sharp, then dull.
Visceral pain, in contrast, originates from our internal organs. It's mediated by specialized receptors, chemoreceptors, baroreceptors, osmoreceptors, and stretch receptors that are uniquely sensitive to stimuli such as ischemia, lack of blood flow, excessive stretching, or distension of hollow organs or chemical damage.
Visceral pain from organs, different stimuli. Afferent fibers carrying these visceral sensations reach the central nervous system via both the sympathetic and parasympathetic components of the autonomic nervous system. Once these signals enter the CNS, the pain impulses are believed to travel by the same ascending tracts as somatic pain, primarily the spinothalamic tracts, ultimately reaching the postcentral gyrus of the cerebral cortex, where a crude level of awareness occurs.
Travels with somatic pain pathways.
Clinically, visceral pain is characteristically poorly localized, often described as a diffuse, deep ache or pressure rather than a sharp, pinpoint sensation. It is also frequently associated with widespread autonomic responses such as salivation, nausea, vomiting, changes in heart rate, tachycardia or bradycardia, and sweating. And of course, this is the classical neurological phenomenon where we encounter referred pain.
Poorly localized autonomic symptoms and referred pain. Understanding these pathways is not just academic, it is the absolute bedrock for the clinical management and treatment of pain. For acute pain, various pharmacological approaches are employed. Salicylates, like aspirin, work by reducing the synthesis of prostaglandins.
Anti-inflammatories.
Local anesthetics directly block nerve conduction.
Numbing agents.
Narcotic analgesics, such as morphine or codeine, incredibly potent pain relievers, work by reducing the emotional and affective reaction to pain. They act on specific opiate receptors located throughout the central nervous system, particularly in the posterior gray column of the spinal cord, where they inhibit the release of key pain neurotransmitters like glutamate and substance P.
Opioids acting on those pain modulation systems we discussed.
It's exactly. For long-term management of intractable pain, particularly in cancer patients, continuous infusion of morphine directly into the spinal cord, either into the subarachnoid or epidural space, has proven highly effective. For chronic pain, newer non-pharmacological techniques are increasingly utilized, including acupuncture, transcutaneous electrical nerve stimulation, TENS, and even the profound power of the placebo effect.
Placebos can actually trigger endorphin release.
There's evidence suggesting the anticipation of relief can stimulate the brain's own endogenous opioid system, leading to endorphin release and pain relief.
When conservative measures are insufficient, surgical intervention can be a profound option for the relief of intractable pain, particularly in patients with terminal cancer. One such procedure is a posterior rhizotomy.
Rhizotomy, cutting the posterior sensory root,
which involves the surgical division, cutting, of the posterior root of a spinal nerve. This effectively severs the pain conduction pathway into the central nervous system at its earliest entry point. It's a relatively straightforward procedure, but a key consideration is that it also deprives the patient of other sensations carried by that root. If the pain is diffuse or widespread, multiple roots may need to be divided to achieve adequate relief.
Cuts all sensation from that root, not just pain. Another more targeted surgical procedure is a thoracic chordotomy. This involves the precise surgical division of the lateral spinothalamic tracts, the main pain pathway, by inserting a specialized knife into the anterolateral quadrant of the spinal cord.
Chordotomy, cutting the spinothalamic tract itself.
This procedure is highly effective for severe intractable pain originating from the lower abdomen or pelvis. It is essential for the neurosurgeon to recall the crucial neuroanatomical detail that these pain fibers, after crossing in the spinal cord, ascend obliquely for approximately 3 to 4 segments higher than their posterior root entry level before truly settling into the lateral spinothalamic tract.
Ah, that oblique crossing matters surgically. Need to cut higher up.
Precisely. Therefore, the lesion must be made a few segments above the highest spinal segment from which the pain originates. A cervical cordotomy can be performed for intractable pain located in the neck or thorax, requiring even more precise and delicate surgical technique given the vital structures in the cervical cord.
Let's now pivot to the intricate world of motor control and its dysfunctions. A fundamental concept here is muscle tone, which is defined as the continuous, partial, and involuntary contraction of a resting muscle, giving it a certain degree of firmness and resistance to passive stretch.
Muscle tone, the baseline tension.
It is fundamentally dependent on the integrity of a simple monosynaptic reflex arc, specifically the stretch reflex, which involves the muscle spindles, sensory receptors within the muscle, the afferent neuron carrying signals from the spindle, and the lower motor neuron innervating the muscle.
Depends on that simple reflex arc.
If any part of this reflex arc is destroyed, muscle tone is completely abolished, resulting in an atonic, soft, flabby muscle that rapidly undergoes atrophy. Normal, finely tuned muscle tone also depends heavily on continuous, modulated supraspinal control from higher brain centers via the descending tracts. While muscle spindles are excitatory to muscle tone, neurotendinous receptors, Golgi tendon organs, are conversely inhibitory, providing a critical feedback loop for regulating muscle tension.
Spindles excite, Golgi tendon organs inhibit, balances tone. Voluntary movement, in contrast to tone, is consciously initiated, purposeful, and involves a complex, coordinated series of muscle contractions directed toward achieving a specific goal.
Voluntary movement conscious, goal-directed.
This entire process is profoundly influenced and continuously refined by a rich input from various sensory systems, our eyes, ears, and crucially our proprioceptors, as well as by stored memory and our emotional state, mediated by limbic structures. The upper motor neurons, encompassing both the corticospinal tracts and the various brainstem tracts, exert their influence over the lower motor neurons, often via complex networks of interneurons.
UMNs control LMNs, often via interneurons.
While the corticospinal tracts are particularly responsible for mediating fine, skilled, and discrete movements, especially of the distal limbs, the other descending tracts mediate more basic, fundamental voluntary movements and play a continuous role in adjusting muscle tone, thereby facilitating easy and rapid joint movements.
Corticospinal for skill, others for basic movement and tone. Clinically, you will frequently encounter the terms pyramidal and extrapyramidal tracts, though these are more clinical groupings than strict anatomical classifications. The pyramidal tract refers specifically to the corticospinal tracts and the corticobulbar tracts to the brainstem, so named due to their highly concentrated bundle of fibers forming the prominent pyramid on the anterior surface of the medulla oblongata.
Pyramidal, corticospinal, because of the pyramids in the medulla.
The extrapyramidal tracts then functionally refer to all other descending tracts that influence motor activity, including the rubrospinal, reticulospinal, tectospinal, and vestibulospinal tracts.
Extrapyramidal, everything else descending. Lesions to upper motor neurons, meaning damage to the cell bodies of these supraspinal neurons or their descending axons within the brain or spinal cord above the level of the lower motor neuron, produce a characteristic constellation of clinical signs.
Okay, signs of UMN damage.
For corticospinal pyramidal tract lesions, you'll typically observe a positive Babinski sign. This is an abnormal plantar reflex where, when the sole of the foot is scratched, the great toe dorsally flexes, points upward, and the other toes fan out. The normal adult response is plantar flexion, toes curl downward.
Babinski sign, big toe goes up. Classic UMN sign.
The why behind this is crucial. Normally, the corticospinal tracts exert an inhibitory influence, producing plantar flexion. When non-functional, a primitive withdrawal reflex appears. The Babinski sign is normally present in infants under 1 year old because the corticospinal tract isn't yet fully myelinated. Other key signs include the absence of superficial abdominal reflexes and the absence of the cremasteric reflex, both of which rely on the integrity of the corticospinal pathways. And of course, there is a pronounced loss of fine, skilled voluntary movements, especially at the distal limbs.
Loss of fine motor control, too. If the lesion primarily affects other descending tracts, the extrapyramidal system, the clinical signs are distinctly different. You will observe severe paralysis, often without significant muscle atrophy, except secondary to disuse.
Paralysis without immediate atrophy.
A hallmark sign is pronounced spasticity or hypertonicity of the muscles, characterized by an increased resistance to passive movement that is velocity-dependent, meaning it's worse with faster stretches. This often results in a characteristic posture. The lower limb is maintained in extension, and the upper limb is held in flexion.
Spasticity. Increased tone, velocity-dependent, Classic posture.
There will be exaggerated deep muscle reflexes, for example, knee-jerk reflex, and often clonus-rhythmic, oscillating contractions, particularly in the flexors of the fingers, quadriceps femoris, and calf muscles.
Hyperreflexia and clonuses.
You might also observe a clasp knife reaction, where the muscle spasticity produces strong initial resistance to passive movement, which then suddenly gives way, like opening a clasp knife, due to neurotendinous organ-mediated inhibition. In clinical reality, it's vital to recognize that organic lesions rarely restrict themselves to only pyramidal or only extrapyramidal tracts. Both are usually affected to varying degrees, profoundly altering the delicate balance of muscle tone and movement control.
Usually a mix of pyramidal and extrapyramidal signs. Conversely, lower motor neuron regions involve damage to the cell body of the motor neuron itself in the anterior great column or its axon within the anterior root or spinal nerve.
Okay, LMN damage signs now.
These can be caused by a wide range of pathologies, including trauma, infections like poliomyelitis, vascular disorders, degenerative diseases such as amyotrophic lateral sclerosis, or neoplasms, tumors. These lesions present with distinct clinical signs. Flaccid paralysis, characterized by a complete loss of muscle tone, making the muscle soft and limp.
Flaccid paralysis, low tone.
Profound muscle atrophy, where the muscle wastes away due to denervation.
Muscle wasting.
Complete loss of reflexes, reflexia, because the reflex arc is interrupted.
No reflexes.
Muscular fasciculation, which are visible, spontaneous fine muscle twitchings that occur with slow destruction of the lower motor neuron.
Fasciculations again.
And ultimately, muscular contracture, where the paralyzed muscles shorten and tighten due to the lack of opposing muscle action. The reaction of degeneration test, involving changes in muscle response to electrical stimulation after nerve damage, further helps to confirm LMN involvement.
Clear differences between UMN and LMN signs. To clarify the various degrees and patterns of paralysis you might encounter clinically, hemiplegia refers to paralysis affecting one side of the body.
Hemi-half.
Monoplegia is paralysis of a single limb.
Mono 1.
Diplegia denotes paralysis of two corresponding limbs, either both arms or both legs.
Do 2. Corresponding.
Paraplegia specifically describes paralysis of the two lower limbs.
Paralower limbs.
And quadriplegia, or tetraplegia, signifies paralysis affecting all four limbs, both arms, and both legs.
Quad equals 4. Abnormal muscle tone provides crucial diagnostic clues about the location of neurological lesions. Hypotonia, or diminished or absent muscle tone, occurs if any part of the monosynaptic stretch reflex arc is interrupted. That critical loop involving the muscle spindle, afferent neuron, and lower motor neuron. It is also a prominent feature in cerebellar disease due to the diminished facilitatory influence of the cerebellum on gamma motor neurons.
Hypotonia low tone, LMN lesion or cerebellar problem.
In contrast, hypertonia or increased muscle tone, which can manifest as either spasticity or rigidity, occurs with lesions involving supraspinal centers or their descending tracts, but crucially, not primarily due to lesions of the corticospinal tract itself. It can also result from local spinal segmental excitation due to sensory irritation.
Hypertonia high tone, UMN lesion, but not isolated corticospinal. Involuntary movements are another set of profound clinical signs that help localize neurological pathology. Tremors are rhythmic, involuntary oscillations or contractions of opposing muscle groups. They can be slow, like the characteristic resting tremors seen in Parkinson's disease, or fast, such as those associated with hyperthyroidism. They can occur at rest, with action, postural tremor, or during purposeful movement, intention tremor, characteristic of cerebellar disease.
Tremors, rhythmic shaking. Different types point to different problems.
Spasms are sudden, often painful involuntary contractions of large muscle groups, frequently seen in conditions like paraplegia due to descending tract lesions not directly involving the corticospinal tract. Athetosis involves continuous, slow, involuntary writhing and dysrhythmic movements, particularly affecting the distal parts of the limbs. These movements typically disappear during sleep and profoundly impede voluntary movement. They are classically associated with lesions of the corpus striatum, part of the basal ganglia.
Athetosis, slow, writhing movements, basal ganglia lesion.
Chorea refers to continuous, rapid, involuntary, jerky, coarse, and seemingly purposeless movements, which may or may not disappear during sleep. Like athetosis, chorea is also associated with lesions of the corpus striatum.
Chorea, rapid, jerky movements. Also basal ganglia.
Dystonia is characterized by frequent, sustained, involuntary contractions of hypertonic muscles, leading to bizarre and often twisting postures and repetitive movements. This is typically linked to lesions within the lentiform nucleus, another part of the basal ganglia.
Dystonia, sustained, twisting postures. Basal ganglia again, lentiform.
Myoclonus is a sudden, brief, irregular, and lightning-fast contraction of an isolated muscle or part of a muscle, often occurring in the limbs. It can be associated with diseases affecting the reticular formation and the cerebellum. Normal myoclonic jerks can occur when falling asleep due to a sudden, temporary reactivation of the reticular formation.
Myoclonus sudden jerks, like when falling asleep sometimes.
Finally, hemibolismus is a rare, dramatic, and severe type of involuntary movement confined to one side of the body, usually involving the proximal extremity musculature, causing the limb to fly about in large, flailing movements. This condition is associated with a lesion in the opposite subthalamic nucleus.
Hemibolismus, wild flinging of one side. Opposite subthalamic nucleus lesion. Let's now bring all this together by examining some major clinical syndromes that specifically affect the spinal cord, typically observed after the period of spinal shock is resolved. First, the devastating complete cord transection syndrome.
Complete transection cord, totally severed or compressed.
This can be caused by severe trauma, such as a fractured dislocation of the vertebrae, a bullet or stab wound that severs the cord, or an expanding tumor that completely compresses it. The clinical hallmark is a complete loss of all sensibility, pain, temperature, touch, proprioception, vibration, and all voluntary movement below the level of the lesion.
Total loss of feeling and movement below the injury.
Clinically, you would observe bilateral lower motor neuron paralysis and muscle atrophy precisely at the level of the lesion, where the anterior horn cells are directly destroyed. Below the lesion, there's bilateral spastic paralysis with a bilateral positive Babinski sign due to the complete interruption of the corticospinal and all other descending tracts.
LMN signs at the level, UMN signs below.
All sensations, from discriminative touch and proprioception, posterior white columns, to pain, temperature, and light touch, lateral and anterior spinothalamic tracts, are lost bilaterally below the lesion, though the loss of thermal and light touch might appear 2-3 segments below the lesion distally due to the oblique crossing of these fibers. Critically, bladder and bowel functions also lose all voluntary control due to the destruction of descending autonomic fibers.
Loss of all sensation and autonomic control below, too.
A crucial distinction. A fracture at the L2-L3 vertebral level, which is below the termination of the adult spinal cord, means there is no direct cord injury, but rather damage confined to the cauda equina, affecting lower motor neurons, autonomic fibers, and sensory fibers, which presents differently.
Injury below L1-L2 hits the cauda equina, not the cord itself, different presentation. Next, the anterior cord syndrome. This syndrome typically results from cord contusion, often associated with a severe vertebral fracture or dislocation, or significantly from injury to the anterior spinal artery, leading to ischemia, lack of blood supply, of the anterior 2/3 of the cord.
Anterior spinal artery problem damages front of the cord.
Or from a massive herniated intervertebral disc. Clinically, it presents with bilateral lower motor neuron paralysis and muscular atrophy precisely at the level of the lesion. Below the lesion, there is bilateral spastic paralysis due to the interruption of the anterior corticospinal tract and other descending tracts. Crucially, there is a bilateral loss of pain, temperature, and light touch sensations below the lesion, as the anterior and lateral spinothalamic tracts are affected by the anterior cord damage.
So motor and pain template touch lost bilaterally below.
However, a key diagnostic feature is that tactile discrimination, vibratory sense, and proprioceptive sensations are remarkably preserved because the posterior white columns, which carry these sensations, receive their blood supply from the posterior spinal arteries and are typically unaffected in this syndrome.
Posterior column spared. So fine touch, vibration, proprioception are okay. That's key for diagnosis. Then we have central cord syndrome, which is most frequently caused by a mechanism of hyperextension of the cervical spine.
Central cord, often from whiplash-type injury.
Yes, hyperextension. In this injury, the spinal cord is typically pressed anteriorly by the vertebral bodies and posteriorly by a bulging ligamentum flavum. Interestingly, radiographs often appear normal, as there may be no overt fracture or dislocation. The characteristic clinical features include bilateral lower motor neuron paralysis and muscular atrophy, specifically at the level of the lesion, due to damage to the anterior horn cells. Below the lesion, there is bilateral spastic paralysis, but with a highly characteristic and diagnostically important finding: sacral sparing.
Sacral sparing, what does that mean?
This sacral sparing occurs due to the precise lamination of both the descending fibers in the lateral corticospinal tracts and the ascending fibers in the spinothalamic tracts, where the upper limb fibers are positioned more medially within the cord and the lower limb fibers are more lateral.
Lamination again. Central injury hits the medial fibers arms more than lateral fibers legs.
Exactly, making the central, more medial fibers, serving the upper limbs, more susceptible to injury in a central cord lesion.
Signs of this crucial sacral sparing include the presence of perianal sensation, good anal sphincter tone, and often the ability to subtly move the toes, even if the upper limbs are profoundly weakened. The prognosis for recovery in central cord syndrome is often relatively good, particularly if the neurological deficits are primarily due to transient edema, swelling within the cord, rather than structural damage.
So arms worse than legs, some sacral function preserved. Prognosis can be okay. One of the most classic and diagnostically complex syndromes is Brown-Séquard syndrome, often referred to as cord hemisection, though a complete hemisection is quite rare, and it's more commonly an incomplete lesion.
Brown-Séquard, half the cord is damaged?
It can be caused by trauma, such as a fracture dislocation, a bullet or stab wound that damages one side of the cord, or an expanding tumor. The clinical features are a fascinating interplay of deficits that are distinct on each side of the body. Ipsilateral, on the same side as the lesion, lower motor neuron paralysis and muscular atrophy will be observed at the lesion level, where the anterior horn cells are directly damaged.
Ipsilateral LMN signs at the level?
Okay. Below the lesion, on the ipsilateral side, there will be spastic paralysis, an ipsilateral positive Babinski sign, and loss of superficial abdominal and cremasteric reflexes, all due to the interruption of the corticospinal and other descending tracts on that same side.
Ipsilateral UMN signs below the lesion.
Additionally, there's an ipsilateral band of cutaneous anesthesia, loss of sensation, at the lesion level itself, caused by direct destruction of the posterior root entering that segment. And below the lesion on the ipsilateral side, there's a profound loss of tactile discrimination, for example, two-point discrimination, and of vibratory and proprioceptive sensations due to the destruction of the posterior white column on that same side, as these pathways do not cross in the spinal cord.
Ipsilateral loss of posterior column senses, fine touch, vibration, proprioception below the lesion. Makes sense, they don't cross.
Now, switching to the contralateral side, the side opposite the lesion, you will find a distinct loss of pain and temperature sensations below the lesion.
Contralateral loss of pain temp, because spinothalamic cross-flow down.
Precisely. This occurs because the lesion on one side of the cord destroys the crossed lateral spinothalamic tracts that originated from the opposite side of the body. Remember, sensory loss typically occurs 2 to 3 segments below the lesion distally due to the oblique crossing of these fibers. Finally, there will be a contralateral but often incomplete loss of light tactile sensation below the lesion due to the destruction of the crossed anterior spinothalamic tracts. This loss is incomplete because discriminative touch, which is conveyed by the posterior white column on the unaffected side, remains intact, providing some residual touch sensation.
Contralateral loss of light touch may be incomplete. What a complex pattern. Ipsilateral motor and posterior column loss, contralateral pain temp loss.
It's a classic neurological puzzle. Another significant condition is syringomyelia, a developmental abnormality characterized by the formation of a fluid-filled cavity, syrinx, and gliosis, proliferation of glial cells, within the central neuroaxis, most commonly affecting the brainstem and the cervical spinal cord.
Syringomyelia, a cavity in the center of the cord.
Its hallmark clinical feature is a classic dissociated sensory loss, a loss of pain and temperature sensations in dermatomes on both sides of the body related to the affected cord segments, often presenting with a characteristic shawl-like distribution across the shoulders and upper arms.
Dissociated loss. Pain temp gone, but other senses okay. Why?
This occurs because the expanding syrinx typically damages the spinothalamic tracts precisely as they cross the midline in the anterior gray and white commissures. Patients commonly suffer accidental burning injuries because they simply do not feel the heat.
It hits the crossing fibers in the middle, so pain temp lost bilaterally in that cape or shawl area.
Exactly. Crucially, in syringomyelia, despite the loss of pain and temperature, tactile discrimination, vibratory sense, and proprioceptive sense remain normal because the posterior white columns, which transmit these modalities, are typically spared in the early stages as they're located more peripherally.
Posterior columns are spared. That's the dissociation. As the lesion expands, it leads to lower motor neuron weakness and muscle atrophy, often beginning in the small muscles of the hand and progressing to the arm and shoulder as the expanding syrinx directly destroys the anterior horn cells.
Spreads outwards to hit the anterior horns, LMN signs enhance arm.
In later stages, due to lateral expansion of the lesion into the white columns involving descending tracts, bilateral spastic paralysis of both legs can develop, accompanied by exaggerated deep tendon reflexes and a positive Babinski response. Furthermore, Horner syndrome, characterized by constricted pupil, drooping eyelid, and decreased sweating on one side of the face, may also be present, specifically due to the interruption of descending autonomic fibers within the reticulospinal tracts in the lateral white column.
It can eventually cause UMN signs in legs and Horner syndrome. Beyond these specific syndromes, the spinal cord could be centrally involved in several other major neurological diseases that every professional should be aware of. Poliomyelitis is an acute viral infection that specifically targets and destroys the lower motor neurons located in the anterior gray column.
Polio destroys LMNs.
This leads to classic LMN signs, flaccid paralysis, and severe muscle wasting, often affecting the lower limbs. It can be life-threatening if it spreads to the anterior horn cells controlling the intercostal muscles and diaphragm, leading to respiratory failure. Multiple sclerosis, MS, is a common chronic autoimmune disease characterized by demyelination, the destruction of the myelin sheath of nerve fibers throughout the central nervous system, including the ascending and descending tracts of the spinal cord.
MS demyelination attacks the white matter tracts.
It presents with a wide array of symptoms like weakness, ataxia, lack of coordination, and spastic paralysis, with a chronic course marked by unpredictable exacerbations and remissions.
Amyotrophic lateral sclerosis, ALS, tragically known as Lou Gehrig's disease, is a devastating neurodegenerative disorder confined specifically to the corticospinal tracts and the anterior gray column motor neurons.
ALS hits both UMNs, corticospinal, and LMNs, anterior horn.
It classically presents with a unique superimposition of both lower motor neuron signs, progressive muscular atrophy, paresis, fasciculations, and upper motor neuron signs, paresis, spasticity, and a positive Babinski response, as both pathways are simultaneously affected. Parkinson's disease, a common movement disorder, involves the progressive degeneration of dopamine-producing neurons in the substantia nigra in the midbrain. While primarily a brainstem disorder, its effects are profound on spinal motor control, leading to characteristic resting tremors, cogwheel rigidity, and bradykinesia, slow movements.
Parkinson's brainstem issue, but affects spinal motor output.
And finally, pernicious anemia, caused by a severe vitamin B12 deficiency, can lead to extensive and often irreversible damage to the posterior and lateral white columns of the spinal cord, as well as peripheral nerves, resulting in widespread sensory and motor losses, including ataxia and paresthesias.
B12 deficiency damages posterior and lateral columns. To diagnose these complex conditions and visualize the often unseen pathologies within the vertebral column and spinal cord, we rely on a sophisticated array of diagnostic tools. Vertebral column radiography using antero-posterior AP, lateral and oblique views remains a foundational imaging technique.
Basic X-rays first.
It can reveal structural abnormalities such as vertebral destruction caused by tuberculosis, tumors, or acute fractures, as well as more subtle changes like pedicle erosion or narrowing in osteoarthritic spurs that might impinge on neural structures.
Computed tomography, CT scans, provide exquisite cross-sectional images of the vertebrae and their associated joints, proving particularly useful for identifying bony abnormalities, disc protrusion, or narrowing of the spinal canal. Spinal stenosis.
CT for bones and stenosis.
However, sagittal magnetic resonance imaging, MRI, has increasingly become the gold standard, often replacing both CT and older myelography techniques.
MRI is king now.
MRI offers unparalleled soft tissue contrast, clearly identifying the vertebrae, intervertebral discs, the posterior longitudinal ligament, the meningeal sac, the Nickel sac containing the CSF, epidural fat, and the delicate nerve roots of the cauda equina, providing a comprehensive view of neural structures in their surrounding environment.
Great for seeing the cord, discs, nerves. And finally, myelography, while less commonly performed now due to the transformative advances in CT and MRI, remains a specialized diagnostic technique. It involves the meticulous injection of a contrast medium directly into the subarachnoid space via a spinal tap.
Myelography injecting dye, less common now.
Much less common. This contrast medium outlines the spinal cord and nerve roots. The technique reveals obstructions, such as tumors or prolapsed intervertebral discs, by demonstrating a characteristic blockage or deviation in the normal flow of the oil-based or water-soluble contrast medium. A normal myelogram would show distinct, pointed lateral projections at regular intervals, where the contrast medium fills the subarachnoid space around each spinal nerve root sleeve.
So we've come full circle, from the dramatic scenario of our horse riding patient suffering a C4 fracture to meticulously dissecting the intricate architecture of the vertebral column. We've seen how this bony sanctuary, when compromised, can lead to such precise and utterly devastating neurological deficits.
Exactly. Our deep dive into the spinal cord's complex internal organization, from the H-shaped gray matter with its functionally specialized cell groups to the myelinated white matter housing those incredibly detailed ascending and descending tracts, each with its unique crossover pattern, illuminates the remarkable, almost unbelievable precision required for every single bodily function. You now possess a comprehensive framework for precisely why a lesion on one side of the cord can cause a loss of pain sensation on the opposite side of the body, or why proprioception is lost ipsilaterally.
What's truly powerful here is understanding that mastering these specific pathways, which ones cross, which ones don't, and precisely where those critical crossovers occur, isn't just academic knowledge. It is absolutely paramount for interpreting neurological deficits after injury or disease.
It's the key to localization.
Forming the very foundation for real-world diagnosis, prognosis, and intervention in conditions that can be utterly devastating. Think about the incredible precision a neurosurgeon needs when performing a cordotomy for pain relief, or the careful, nuanced management of a patient in spinal shock. This deep dive has truly given you the tools to understand this organ like an elite professional.
A profound thought indeed. This level of understanding moves beyond simple facts into true clinical insight.
It really puts into perspective the remarkable resilience of the spinal cord and yet how devastating its injuries can be. This raises a provocative thought for you to ponder. We've explored the current state of neuroanatomy and physiology, but what further breakthroughs in understanding neuronal regeneration or entirely novel pain control mechanisms might allow us to literally rewire these vital pathways in the future,
Rewiring the cord.
offering even greater hope for recovery and function for patients like the one we discussed today.
A truly exciting prospect for the future of medicine. The potential is enormous.
Thank you for joining us on this deep dive into the hidden yet absolutely critical highways of the spinal cord. We hope you feel not just informed, but profoundly empowered by this knowledge. Until next time, keep digging.